Good morning, and welcome everybody to the American College of Surgeons Surgical Healthcare Quality Forum in New York. My name is Fabrizio Michelassi. I'm the chairman of the Department of Surgery at New York Presbyterian Hospital and Weill Cornell Medical College. We're very pleased to be hosting this forum in partnership with the American College of Surgeons, and I would like to thank the hosting institutions, New York Presbyterian Hospital and Weill Cornell Medical College. We as surgeons are profoundly interested in the quality of care of our patients and the ability to reduce complications and improving the quality of life of our patients who have been so interested forever. But now better than ever and more timely than ever, we need to focus our attention on our quality of care. And probably for the first time, we have tools to do that. And today, the forum will talk about those tools, how to analyze them, how to take advantage of them, and how to really measure our care and our results. And the theme of the forum today, as you know, is improving surgical quality, a data-driven approach. This resonates particularly well in New York City and New York State. After all, it was New York State that pioneered the public reporting a long time ago, 20 years ago, with the New York State Cardiac Surgery Reporting System. So with this experience, I think that we probably better than most know the advantages and potentially also the challenges of public reporting. And I thought that this forum was quite timely, and very pleased to have several healthcare and surgical leaders here today to address the issue of quality in surgery. And I'll start introducing the first one, Dr. David Hoyt, who is currently the Executive Director of the American College of Surgeons, a position that he took 3 years ago after spending 35 years in Irvine, where he was chairman of surgery of the department. He was the Jack Connolly Professor of Surgery, and he also was the Executive Vice Dean of the University of California in Irvine. It's a pleasure to have David as the Executive Director of the American College of Surgeons, and there is no doubt in my mind that this push for quality has been initiated by David 3 years ago, and is based obviously on a long-term interest of the American College of Surgeons on quality for surgical care. David, thank you very much for participating.
Well, good morning, and thanks everybody for coming this morning. This is really exciting. I want to start out by recognizing the contributions of Dr. Michelassi. I really value and honor his friendship over the years, but his leadership in bringing this to New York City is really what's made this successful. And I believe this will be and prove to be the largest and perhaps the most important conversation we've had in the Inspiring Quality campaign. What I'm going to try and do for a few minutes is frame this for you as we get into the more formal presentations. But we decided 3 years ago that the most important thing that our legacy as surgeons was really based upon our commitment to our patients for high quality. It frames our programs for quality management. It frames our commitment to patients in terms of our own education, and it really defines what we do. So as we begin the celebration of 100 years as an organization, which we're in the middle of doing, we really want to look at this as an opportunity to try and inspire ourselves and recommit, but also inspire others toward these goals and raise the collective consciousness and the public trust toward quality management, particularly at a time when healthcare is going through such great transitions. Now again, historically, this has been our roots. And if you look at the timeline, this is a series of the programs that the American College of Surgeons started going back to 1917 with the initial hospital standards. In fact, the first public reporting of those standards occurred at the Waldorf Astoria Hotel in 1918, right here in New York City. And although it was in retrospect, a very difficult discussion, it just shows the commitment that the college has had on behalf of their patients. In fact, that program became what we now know as the Joint Commission, and although it spun out of the college, it's really set the standards for what a hospital is in terms of care of a patient. Other activities that have been really seminal have been the Commission on Cancer, which is a consortium now of over 50 organizations in cancer care, defined standards for cancer centers, the Committee on Trauma. More recently, the clinical trials effort in cancer, the bariatric surgery program, the breast center standards, and then even more recently, the NYSQIP program have been a manifestation of a set of principles. And as we step back and say, what have we learned over this 100 years about quality management, it really becomes the principles that we've put forth that I think each of you got one of the cubes as you came in. And I just want to go through what we've learned. The first is to go through a process where you actually establish standards. You write them down. You do this through research when available, through consensus when not. They're nationally benchmarked, and they become the way we define our expectations, both with the public and patients and amongst ourselves, for what we consider to be best practice. The second is to commit to actually build out the infrastructure in our hospitals, in our practice environment. It has specific implications for staffing levels, the mix of specialists, the kinds of equipment, the commitment to use of patient safety devices like checklists, and information technology. The third principle is to, from the beginning, commit to measurement of performance. And the implication there is that we will take the initiative to build databases, to measure appropriate outcomes, to measure performance, and use appropriate data, which has to be backed by medical charts, has to be validated, has to be inclusive of post-discharge outcomes, and continuously updated. And the fourth, and perhaps one of the most unique things in medicine, is the commitment to, through peer review, undergo external verification through a peer review process to, in fact, assure the public that what we say we're doing, we are actually doing. When you put a sign in front of your hospital ER that says you're a trauma center, what you're really saying is that you have subjected yourself not only to performance measurement, but to external validation. And that, if you will, is really perhaps the most important thing we can do on behalf of our patients. Now, this happens to be aligned today with the national agenda. And if you look at the quality objectives of Secretary Sebelius through the National Strategy for Quality Improvement, this was published about a year ago. Better care, healthy communities, and affordable care are the triumvirate of principles that this is based on. Similarly, the largest payer, CMS, is based on that same kind of commitment, really based on Don Berwick's idea of the so-called triple aim. We're improving the experience of care, improving the health of populations, and reducing per capita costs becomes the goal. And finally, our think tank nationally, our conscious to a certain extent, the Institute of Medicine has published a series of reports in the last 5 years designating the so-called learning healthcare system approach as the national goal. And what this really says is that we're going to put in concept and contextualize the use of evidence in the way in which we practice. And so for the first time, we have alignment between payers, regulators, and in fact, our intellectual arm of medicine, again, committing to the quality agenda. Said another way, maybe the reason we should do this goes back to the principles that Ernest Codman put forth over 100 years ago in introducing the first measurement of performance of surgical care. And he said, basically, because we can, we should. And I don't think that's different 100 years later. Now, you're going to hear today the detail about a lot of programs and experiences, But how can we bring this agenda of improving quality together with what is all of our responsibility, and that is trying to lower the cost of care as we have this national discussion. And we have found literally common ground, and I want to give you an example of this that we're using to really try and foster this discussion. It's based on a program you're going to hear about, the NYP-Weill program, which is a database that measures outcomes of general surgery and vascular surgery patients. And you'll hear from Cliff Coe, and he and his colleagues have run this program in the college for several years. They now have this across many, many large hospitals, and with the number of participants growing. And what they've been able to show is that when you benchmark outcomes and ask hospitals to then look at their performance, that you actually see a reduction in complications, you see an improvement in mortality, and the rate of that is about 1 complication per day in a 400-bed hospital, which is a believable number. If you take that and translate that into dollars, and this is where the cost and quality piece comes together, and you attribute about $11,000 or so to a complication, which is relatively modest, you're actually talking about an average hospital being able to save somewhere between $3 and $6 million a year. You multiply that times the American hospitals in this country, and you very quickly get to billions of dollars of saving. It's that kind of program participation and then enjoying the cost reduction associated with that will, I think, fulfill our contract with our patients to improve the efficiency and the cost and improve the quality of health care. And that's why we're so passionate about this. In a sense, we are going through an evolution in medicine, and surgery, I think, is taking the lead in this, of really defining professionalism. From a time 100 years ago when we oftentimes did things through autonomy and authority, and I'm not saying that that was wrong in any way. That may have been the way we naturally had to evolve 100 years ago. But today, really the value system is going to be based on collaboration, evidence, measurement, and really transparency in the public interest. And accountability is going to be the word that we use to measure our success. So I think the programs you're going to hear about today really fulfill that public trust. I'm going to end my introduction with a little video that we put together that tries to just sort of inspire us all about what we do every day.
Well, thank you very much, David. We as surgeons can be only proud to have you at in the leadership position of the American College of Surgeons and giving such an inspiring leadership in terms of quality improvement for our patients and for our nation. It is now my pleasure to introduce Dr. Lori Glimcher, the Dean of Weill Cornell Medical College. Dr. Glimcher is the Stephen and Suzanne Weiss Dean and Professor of Medicine at Weill Cornell, and she also serves as Provost for Medical Affairs of Cornell University. Dr. Glimcher came to New York on the 1st of January of this year. She has provided incredible vision and leadership to the medical college. Prior to that, she was in Boston at Harvard, where she was the Irene Hines Given Professor of Medicine in the Harvard School of Public Health and Professor of Medicine at Harvard Medical School. And it is with great pleasure that I'd like Dean Glimcher to come to the podium and address all of us on the importance of quality for a medical school and for our medical students.
Well, first of all, welcome everybody to Weill Cornell. I'm really thrilled that we could host this really important event. And I have special thanks to Dr. Michelossi for inviting me to do this. And that's because I just learned from Dr. Hoyt that this is going to be on YouTube. And if it's on YouTube, my older son, who is training to be a cardiothoracic surgeon, might actually watch it, and I'll get some respect from him for the first time. I think that the American College of Surgeons has really been a leader and has a very long and inspiring history of leadership and innovation in quality improvement initiatives. And in many ways, surgeons are light years ahead of many other medical subspecialties in spearheading quality improvement initiatives in their laser focus on reducing infection and surgical complications and their goals in discharging patients well and in a short period of time. Through large risk-adjusted databases of morbidity and mortality, surgeons can look broadly at systems for ways to improve clinical outcomes, both from the 20,000-foot level and at the level of the individual practitioner. So I want to focus my presentation from the vantage of undergraduate medical education, and I'm going to provide a brief background to quality improvement, patient safety, and medical education, discuss some of the theoretical underpinnings of QI patient safety curricula, and describe some of the current topics and teaching methods, and most importantly, the learning outcomes of the QI curricula here at Weill Cornell. And to briefly mention some of our educational activities in QI and patient safety here at Weill Cornell. And then I'll conclude with some recommendations for improving medical education in this area. Well, as you all know, the quality improvement movement began in the mid-20th century, but was really catalyzed around 2000 by two IOM reports. To Err is Human, which documented the high number of medical errors and deaths due to medical error in the U.S., and Crossing the Quality Chasm, which called for fundamental changes in the healthcare system to improve quality and create a culture of safety. Subsequently, a series of forces converged to form a perfect storm for improvement in QI, patient safety curricula, and medical education. And these forces include accrediting bodies, two new ACGME competencies, practice-based learning and improvement, and systems-based practice. There was a push by the AAMC and the LCME to include QI in the curriculum of medical students. And this was accompanied by improved data collection systems, as Dr. Hoyt has pointed out, that allowed continuous tracking and updating of outcomes and complications, such as the electronic medical record, NESQIP, and the federally funded Patient-Centered Outcomes Research Institute. Hospital accreditation standards and insurance audits that come with fines or increased costs for delivering bad care, and this was further mandated in the 2010 Affordable Care Act, which requires health plans to report on their QI activities. And finally, rise of patient consumerism with enhanced patient interest in hospital and doctor performance, publication of hospital ratings in morbidity, mortality, safety on the internet. There have been customer review sites, and of course, an aggressive legal profession looking for malpractice dollars. Well, since the publication of the IOM report in 2000, subsequent studies have shown that the problem of medical errors continues. Consumers Union, which publishes consumer reports, estimates there are still more than 1.5 million medication errors and 100,000 deaths in the U.S. due to medical errors. Many of the year 2000 IOM recommendations have not yet been implemented. 24 states still don't have any medical error reporting systems in place. Many hospitals still do not have computerized physician order entry systems. And a recent report by the DHS Inspector General that was released in January of 2012 found that hospital incident reporting systems do not capture most patient harm. So hospitals still remain hazardous to our health, unfortunately. So as you know, much of the QI curriculum is based on the Institute of Healthcare Improvement's 8 knowledge domains for the improvement of healthcare, and I've shown them here. And in a nutshell, these involve assessing the needs of our patients, understanding healthcare as a complex process and system, using measurement to understand the variation of performance in processes and systems, methods and leadership skills for making changes in the healthcare system, methods and skills needed to work in groups, because working in teams is really the future, recognizing the need for new knowledge in one's personal daily health professional practice, and understanding the social context of healthcare at both the local, regional, national, and global levels, including healthcare financing. And of course, professional knowledge of one's own clinical area or specialty. QI patient safety curriculum obviously needs to start early and be part of the medical education continuum, inculcated early on in medical school, developed through residency, and then fully practiced and modeled at the faculty attending level. Because curriculum is only going to be successful if it's closely matched to the learner's level, and as shown here in the classic Dreyfus levels of professional development, medical students are at the novice and advanced beginner level on the road to becoming experts. Orgrink, in an important paper in Academic Medicine in 2003, laid out a framework for teaching medical students and residents about practice-based learning and improvement, and that served as a foundation for the development of many subsequent programs. Ogren's model combined the IHI improvement domains with the Dreyfus model of professional development. And in his model, beginning students would be exposed to didactics about quality, cost, and the healthcare system, and also have experiential activities where the students themselves could design a project to change the quality of an area that's relevant to them at that point in their training. For instance, first-year students could focus not on clinical problems, but on how change could be effected to improve the quality of teaching in gross anatomy. More advanced medical students ideally would engage in actual clinical improvement projects, that is, identifying a need in the clinical setting, developing an aim, working collaboratively with others, such as residents, nurses, other staff, and identifying, collecting, and displaying measures of care and cost, and then recommending changes to a process, perhaps to the hospital staff or the administration. And examples might be projects that make sure that patient weights or BMIs are documented regularly, patients are screened for smoking, diabetes patients receive adequate foot care. And what's important about these projects is that they would empower students with the notion that they could actually make real changes that mattered, and it would also bring theory and didactics into the real world of clinical practice. Well, since Ogren's theoretical framework, a number of QI programs, as you know, at the UME level have been developed and implemented. Wong and his colleagues did an excellent meta-analysis type review of QI curricula, and only those that met rigorous inclusion criteria were included. That is, studies that described a curriculum that explicitly defined as its goal exposing medical students or residents to concepts in QI and patient safety, and outlined specific teaching methods. The best evidence medical education protocol was also used to assess the relative strength of the findings. So Wong studied curricular outcomes based on Kirkpatrick's model that's shown here. The gold standard, of course, is results. That is, do our programs yield real benefits for our patients? The low-hanging fruit is learner satisfaction. And on this slide, you can also see the range of intermediate outcomes, such as changes in attitude, improvements in knowledge and skills, transfer of behavior to actual practice, and a change in clinical processes, for instance, how, when, and in whom Foley catheters are placed. So here you can see the general content of most curricula on QI and patient safety in programs that have been studied. QI content focuses on quality of care in general, continuous quality improvement, the PDSA, Plan, Do, Study, Act cycle, which really comes from the business world, about effecting change auditing of data with feedback, similar to ACS's NYP database, process, mapping, change management. And safety content focuses on systems thinking and root cause analysis, human factors behind errors, error reporting and handling of errors, and creation of a safety culture that doesn't blame others but seeks understanding of causes and then suggests solutions, so constructive. Now, there is a major problem with medical education curricula in QI patient safety, and that's, that they continue to be taught largely in the classroom, sort of away from real-world setting of patient care, and they still use the passive pedagogy of didactic lectures. So there's some more innovative programs that are getting students involved in the planning and design and implementation of original QI or patient safety projects that can have really exciting results. So when I'm showing you here the results of Wong's meta-analysis review of 28 studies at the medical student and residency level. And he's judged these according to Kirkpatrick's levels of learner outcomes. So not surprisingly, most studies of medical students achieved only the lower hanging fruits of learner satisfaction, improved attitudes to the importance of QI safety, and enhanced knowledge about QI patient safety practices. Postgraduate programs were more successful in achieving all of that, plus some transfer of behaviors to clinical practice. The gold standard of achieving real benefits for our patients it still remains, I think, largely elusive. But the data showed that there were 4 critical ingredients for the successful implementation of curriculum on QI that included the learner, the teacher, the curriculum itself, and the learning environment. So the learner obviously has to be enthusiastic about what he or she is doing, and so you need to carefully match QI sessions in the curriculum to learner level. So first-year students, for example, are often more concerned with passing biochemistry than hearing about patient safety issues. The second component is the teacher, and for this we need faculty buy-in. We need to have adequate faculty expertise and role models who have dedicated teaching time, and they receive faculty recognition and support for their work in QI and patient safety. The third component is the curriculum, which we believe should combine both didactics and experiential methods and denote adequate time to a QI curriculum. And interestingly, from these data, it was concluded that either a standalone QI curriculum or one that's integrated into existing courses and clerkships seems to work. And finally, there's the learning environment, because you have to have institutional buy-in at the highest levels with the curriculum linked to hospital operations, and very importantly, you have to have robust information systems that allow easy access of learners to aggregate de-identified healthcare data such as NYP. So let me just give you a few words about what we do here at Weill Cornell. QI and patient safety is covered in all 4 years of our curriculum. In the first 2 years, it's covered in the Medicine, Patients, and Society course. Weill Cornell's doctoring course students are introduced to the concept of medical error, general concepts about patient safety and QI in the U.S. healthcare system, and the role of health information technology in quality improvement. In clinical clerkships, students attend M&M conferences, and in the surgery clerkship, students participate in the SAIL lab, where they learn basic surgical skills and safety, and then they're exposed to the NSQIP database in conference and discussions at the same time. And we have a unique clerkship, which is required, a public health clerkship on health policy in the 4th year. So let me just say a word about our 3rd-year surgery clerkship. All of our students spend about 15 hours in our Skill Acquisition and Innovation Lab. We call it SAIL. And here students learn and practice a wide range of skills, including urinary catheterization, suturing, surgical knot tying, basic laparoscopic skills, and central venous catheterization with ultrasound. There's a major focus on patient and clinician safety, teamwork, and teaching methods used are both concise, didactic key points that are formatively guided by repetitive simulations and mental practice of the surgical skill. And some of our tools include reinforcement of hand hygiene protocols, gloves, partial task trainers, knot tying boards, and real suturing on inanimate simulated tissue with needle drivers, adds and forceps, suture scissors, and so forth. And we have a real ultrasound machine on central venous catheter simulators. We also have real urinary catheter kits and real full surgical laparoscopic video towers and laparoscopic instruments to manipulate inanimate objects. And importantly, there are team training exercises on communicating with the first assistant surgeon and the circulating nurse. And this for optimal laparoscopic visualization and OR team efficiency. So the students really love this. And they get a real feel for safety and efficiency and teamwork and the need for continued practice of learned skill sets. Of course, all of you are familiar with NSQIP. It was originally started in VA hospitals and then expanded to private hospitals. So as part of the 3rd-year surgery clerkship, Weill Cornell students participate in the conference in which NSQIP data are discussed and analyzed. And this has proven to be a wonderful opportunity for our students to see how real data about performance can be fed back to practitioners and then analyzed for causes and possible solutions at the level of the system as a whole or at the level of the individual practitioner. Most recently, for example, the NSQIP data were studied for ways to reduce the incidence of UTIs and surgical site infections on the surgical service of New York Presbyterian. And then we have a 4th-year public health clerkship, and that's a 2-week required intensive clerkship, provides a broad overview of cutting-edge health policy issues, for which we absolutely need to equip our students to understand and be able to use. And this clerkship, it uses a mix of lectures and seminars, student research presentations, and field trips as well to interview some highly placed health policy experts in New York City. Areas of the course that are relevant to QI include measurement of quality, quality assurance initiatives, including pay for performance and comparative effectiveness, types, causes, and costs of medical errors, how to communicate with patients about errors, and what are the mechanisms to ensure patient safety, and finally, what are the QI initiatives in Medicare and Medicaid programs. So I want to conclude with several recommendations for moving forward with curriculum development at the undergraduate medical education level. I think, there needs to be buy-in for the importance of QI patient safety curricula at all levels, learner, teacher, institution. And for that, we need more faculty experts and role models And we also need to recognize and reward our faculty who teach in this area, which is so important. Curricular interventions need to be timed properly to the learner's stage of professional development, and we have to have adequate time that's provided for both the learners and the teachers. We also need, I think, to better integrate formal didactics in QI patient safety theory with data analysis audits like NSQIP, and then with experiential activities in which students themselves can identify a problem or a need and then design and implement a project that's going to result in actual systems change and improved patient outcomes. Finally, we need to measure whether our curriculum is working, so we need better metrics in our own medical education studies of learner outcomes. Thank you for listening to this. I think this is an incredibly important area for all of us, and I'm certainly a big supporter of this in our own medical education curriculum. Thank you.
Thank you very much, Dr. Glimcher. I'd like to proceed with the next speaker, Dr. Foster Geston. Dr. Geston is the Medical Director of the Office of Quality and Patient Safety in the New York State Department of Health. Dr. Geston is a trained internist and is a member of the Committee on Performance Measurement at the National Committee for Quality Assurance, and a member of the Measure Application Partnership Coordinating Committee of the National Quality Forum. Most importantly, Dr. Geston provides oversight in quality at the Department of Health level, performance measurements, and clinical improvement within health plans and public insurance programs in New York State. Dr. Geston, thank you very much for participating.
Good morning, and thank you so much, Dr. McAlashley, for inviting me into New York Presbyterian Hospital and, Weill Cornell Medical College for hosting this, the American College of Surgeons. I too, hoping to get some credibility from my 15-year-old about YouTube, although I do fear that this might not get as many hits as the cute cat that opens the refrigerator, but hope springs eternal that might happen. It's a pleasure to be here and talk about such an important topic with folks who have been leaders both at an organizational level, at a national level, on a hospital level, and so on. And I have a sense that we may be speaking to the leadership and to the choir, and that part of our conversation, part of our challenge as we leave here today is how do we spread this not only within the institutions that you work in, but among all the institutions and providers in New York to get the kinds of outcomes and the kinds of changes that I think we're all looking for. Dr. Hoyt, I think, teed up in a perfect way the opportunities, both the history and the timeline, and I think the opportunities and overlap between what's going on nationally and statewide in terms of healthcare reform, and concern about triple aim, concern about costs, concern about the national quality strategy, and the way in which it dovetails and with the initiatives that we're talking about today in terms of improving quality. So what's the landscape and what's going on? And again, I think this is probably very familiar to this audience, but there's a lot going on in the background, I think, that is driving the current amount of activity and thought about measurement and around improvement and quality and safety. And I think that they're good things, although some of them present some challenges, I think, to all of us. Healthcare and healthcare costs are, I would submit, the dominating force behind much of the conversations going on, including the current quote-unquote fiscal cliff, which is only actually the beginning of a series of fiscal cliffs that we're all going to have to contend with related to healthcare quality and healthcare costs. So at the federal level, the state level, budget discussions, at the local level in terms of affordability and quality and value of healthcare, union and management negotiations have been for a long time, big negotiations each year around healthcare and healthcare benefits on healthcare costs, as well as we're starting to see again this conversation going on that happened in the 90s around employer competitiveness and global competitiveness in a world economy, and the way and the impact of healthcare, not only in terms of its costs, but also in terms of its outcomes on the workforce. I think at this point, virtually all studies show that for the large part, there is not a linear relationship between how much we spend on healthcare and what kinds of outcomes we achieve. So this is also driving the conversation about the need for intensive evaluation and measurement of where our expenditures are going in healthcare. And then we have variation that projects like the one we're talking about are able to project so clearly variation in mortality, variation in complications, variations in costs and clinical outcomes, all of which, while impacted by patient characteristics, are not completely explained by patient characteristics. So I think this is part of the overall context. I think going back to the costs and cost challenge, I think the good news is that there is increasing evidence that complications and poor quality actually is costly not only to the healthcare delivery system in general or to payers or to government, but actually when you dig into the nitty-gritty of reimbursement to hospitals and hospitals who are trying to figure out a way to be more efficient, that while it's true that to some degree complications and having complications can increase reimbursement, there's a lot of growing literature that suggests that increased reimbursement does not compensate for the increased costs of care, let alone the avoidable morbidity and mortality. The other Y measure, again, we can debate and discuss the value and the issues around the data sets that are used to measure quality, but we look at the health department quite seriously at data that compares New York to other states. We, like you, frequently when we don't look good, say our patients are sicker, the data's wrong, we don't like it, but there is a convergence of data around certain elements that are pretty hard for us to continue to ignore. This is from the Agency for Healthcare Research and Quality. It's in a program called State Snapshots in which they look at various kinds of performance at a state level compared to national. As you can see, while at least in the measures that are used here, about 4 of the 33 measures were better than average, about 9 were about average, about 20 were worse than average. And I would say one of the things that we see consistently for New York in terms of being last, as in 50th in the nation repeatedly, is avoidable readmissions, which is, again, part of the reason why that's been so prominent in terms of discussions about improvement. This happened to come out in Crane's the other day, Crane's Health on the 13th. This talks about another aspect of quality in the way in which it's impacting us. New York ranking 3rd highest nationwide in projected losses due to medical malpractice. Average loss for hospitals in New York State of $4,000 per hospital bed per year. You know, I looked at that number and I think it must be wrong. It just looks too enormous to be true. And then, 1/3 of the costs they describe are claims related to hospital-acquired issues, including infections, bed sores, medication errors, objects left in patients during surgery. Clearly, a lot of opportunity for focus. We see a tremendous amount of variation, just to highlight a few things. And again, leading up to the conversation this morning, but I expect that we'll have some lively conversation about this afterwards. I certainly hope so. We most recently looked at risk-adjusted using administrative claims of sepsis mortality, see a range between 15 and 36%, understanding that risk-adjusted administrative data is not as good, not as clinically based as chart data. But we believe that this probably, while in the particulars of specific hospital performance, may not be the exact right number, that the range is probably not inaccurate. We look at some of the AHRQ measures on postoperative sepsis for elective surgeries. We see a range, again, looking across hospitals in New York between 4 and 1,000 and 44 and 1,000. Again, I would urge you to consider, even if you don't like administrative data, even if you think the data may be off, it doesn't explain all the variation that's there. It was mentioned a history of looking at cardiac services, probably one of the longest trajectories of measurement and evaluation and improvement related to a specific surgery. And again, in this area, both in New York, but I would submit beyond New York, it's really the Cardiac Advisory Committee, cardiothoracic surgeons, cardiologists, and hospitals in New York that have really made a difference. And we see even today, in terms of PCI mortality, risk adjusted, this is a clinical database, variation from 0 to 2.29%, and CABG mortality between 0 and 3.97%. And again, important context, which I'm not showing, is how these rates have decreased over the years. That's a tremendous success story, as well as the fact that we have seen real improvement in narrowing of the rates over time. And New York does well compared to many other states with respect to those. Potentially preventable readmissions, I touched on looking at that. You can see a range of about 1.5% to 22.5%. So the variation is, and known variation, we can debate and discuss whether those are the right numbers or not, is certainly part of the driver about wanting to look at measures and improve care. A little closer to home, again, these are a number of process measures taken from the Surgical Care Improvement Project, from CMS QualityNet, looking at the last year at New York State hospitals. If you look at composite skip measures, the range is about 65 to 100%, and so on. I just picked out a few of these measures to kind of give you a sense of what some of the variation and what some of the range is. I won't belabor this slide. So all of that said, we have, as some of the previous speakers teed up, some real challenges in terms of how we actually do the work of getting the data and doing improvement. It doesn't come easy, it doesn't come cheap, and all the data, particularly data that's in the public space, deserves a tremendous amount of scrutiny and consideration. I think the idealized measure that we're looking for, first and foremost, serves the purpose of improving care quality and patient safety, that it is on point towards that goal, and that the information itself, or the process that happens after the information is collected, which after all is where the action is in fact actionable, that it's believable, it's understandable, and that it can be, in some cases, deconstructed to understand what needs to improve. And I think the whole field of quality and safety has grown from one in which the conversation is about who did what wrong to what are the systems that need to be put in place so that the likelihood of a safe and a high-quality outcome is more likely than not. Measurement needs to be transparent and accountable. Black boxes around risk adjustment, black boxes about ways in which the measures or the benchmarks are determined, I think don't work anymore. And there needs to be accountability related to the measure. I think Dr. Hoyt put that up and mentioned that this begins with standards. It begins with an evidence-based set of standards. As strong as the evidence base is, and that is clearly a challenge related to measures in quality and safety. And then it needs to iterate. It needs to improve over time. It needs to change over time. This is an extremely dynamic area, and one of the challenges of measurement is what seems like a good measure, a good quality measure today, can be changed by an article or two or new findings, and the process of doing that needs to be fast and needs to keep up. Measurement ideally flows from care processes themselves. That is, it's not an add-on activity. I would say most of us that are involved currently in the mechanics of doing measurement, this is really sort of an added-on responsibility. It doesn't naturally flow from care in most cases. We're a long ways away from that happening, but that's the direction that we need to go in. Clearly, having measures that are valid and reliable, that is, they've been tested, they've been road tested, people understand what works about them, they can be audited, and obviously, when you're talking about outcomes, less so for process, but clearly for outcomes, risk adjustment is critical. The measures need to be meaningful. They need to be meaningful and important not only to clinicians, but to the public at large, and I'll talk about that in a second. So there is often this sort of raging debate about whether you report or whether you don't report, and my sense is that this is really a false dichotomy. The argument that I would put forward is that measurement for improvement and measurement for reporting are both important, they both have value, and the issue is really about balance. Recent health grades just came out, and one of the pieces in there show that about 96% of consumers felt it's their right to have objective information about hospitals, and I think that that's the world that we live in. We have a number of examples, I'm getting close to time, of cases in which there is reporting, whether it's cardiac services, hospital-acquired infections, some of the things I mentioned, registries. And I think the registries, like what we're talking about today from the American College of Surgery, has tremendous value in looking not only at process measures, but being able to look at outcomes, being able to do risk adjustment, being able to look at longitudinal analysis and do research. The challenge for us collectively is the voluntary nature of this, and whether the right folks and all the folks are participating in these registries. This slide just gives a sense of what's possible. This is just looking at New York over time, looking at central line infections. Tremendous improvement that's happened in New York and nationally. This is not because of public reporting, although I like to think that part of it is, I think, largely due to the fact that there were, as Dr. Hoyt mentioned, emphasis on standards, on measurement, and tools that were able to be, that were evidence-based and effective, that have been implemented across hospitals in New York State and nationally. So we have a number of perils and challenges in terms of measurement. The process measures need to be closely connected to outcomes. If they're not, that's a challenge, and that's been questioned. Some skip measures, risk adjustment, which has been mentioned, and then the unavoided consequences that everybody worries about and should worry about. Does measurement and public reporting lead institutions and providers to avoid complicated cases? How does this impact vulnerable hospitals? And the issue of finite resources, what gets measured gets attended to what degree does that crowd out or exclude other kinds of activities, including improvement activities? There's too many measures. We can talk about that, some confusion about all the various reports that are out there. And then there's the issue of what's good, what's the right benchmark. And if a state like New York on some measures is out of step with national, do we need to think about really using national measures? What's the right comparator group? And I think there's not a single answer to that. So going forward, clearly the kind of leadership that ACP and ACS has shown in terms of leading the way in this initiative, I think, is critical, not only in the development, but also in the implementation. And by implementation, I also mean the dissemination and being able to make sure that it's not just a percentage at the top of hospitals that are engaged in this, but all hospitals. There needs to be recognition, like it or not, that that doctors and surgeons are not the only folks playing in this space or in this game, that there are other interested parties, and that's going to have to be negotiated and dealt with, but it includes payers and it includes patients. There's a parsimony issue that we're challenged by, and as somebody mentioned, can electronic health records, can we build those in such a way that they lead us to that promised land where the measurement is not an artifact on top of or after the end of the day that's done, but really can flow. Data and information and measures can flow from electronic health records. Haven't seen it yet, or haven't seen it, a highly visible example of it, but hope springs eternal. So thank you so much for listening, and look forward to the discussion.
Thank you very much, Dr. Gaston. It's now my pleasure to introduce Dr. Stephen Corwin. Dr. Corwin is the Chief Executive Officer of New York Presbyterian Hospital, a position that he has held since 2011. Prior to that, he was the Executive Vice President, Chief Operating Officer for New York Presbyterian Hospital. Dr. Corwin trained in internal medicine and cardiology at Columbia Presbyterian Medical Center, and under his leadership as the Chief Executive Officer, and prior to that as Executive Vice President, a lot of attention has been paid to quality and delivery of care in this institution. Dr. Cornell, pleasure to have you.
Thank you, Fabrizio.
Let's have a picture. All right.
Well, thank you, Fabrizio. And for those of you who know Dr. Michelozzi, he usually plies you with a nice dinner in a nice restaurant and a glass of Italian wine, and then he pops the question, would you appear at a particular conference? So that's, for those of you who don't know Dr. Michelozzi, beware. I'd like to follow up on what Dr. Geston said for a moment before I start, and that really is this issue of the transformation of our delivery system. That's really what I'm going to be talking about today in terms of how does quality relate to the transformation that we're undergoing in American healthcare. If one was to say at the beginning of this past year, is everything settled, obviously the answer would have been no. We didn't have a presidential election. The Supreme Court was about to rule on aspects of the Affordable Care Act. But I think that as we've progressed through the year, a couple of things are very clear. The individual mandate was upheld by the Supreme Court, hence the central tenet of the Affordable Care Act, and the president was reelected. Whether you voted for the president or didn't vote for the president, one of the issues was the Affordable Care Act going to be upheld, or was it going to be repealed in some manner or means? Was CMS going to continue down the road of implementing various aspects of the Affordable Care Act? And I think that that's settled. So we're in the midst of this transformation, and the question is, how do we as providers become and indeed advocate for solutions as opposed to being perceived as part of the problem? So what are we confronted with? What am I confronted with as a chief executive? Obviously, the challenges are self-evident. Dr. Geston referred to a number of them. Limited peer accountability. We have fragmented care transitions. This results, obviously, in a whole array of cost issues. We have a quality improvement structure that's developing but not developed. Our information technology is very scattered. There are places that are heavily dependent upon electronic records. There are places that are not, and our ability to connect through health information exchanges is, I think, nascent at best. We still are relying on procedure-based reimbursement. If you do it, you get paid for it. If you don't do it, you don't get paid. And obviously, as a nation, we're confronting now a burden of chronic disease. So if the public health problems at the beginning of the 20th century were clean water and clean air and infectious diseases, the public health problems obviously in the 21st century are diabetes and asthma and obesity, etc. You cannot talk about quality in the absence of talking about healthcare reform, because at its core, the Affordable Care Act was designed to address three things simultaneously. As imperfectly as they may have addressed it, they needed to address cost, access, and quality. And the tenet behind that was that the interrelationships amongst those three divisions, as it were, are so profound that unless you attack all three simultaneously, you're not going to be able to deal with the set of issues that we're dealing with. So obviously now what we're talking about is, and the fiscal cliff is a perfect discussion, like it or not, there are going to be reduces in price, and people want to reduce utilization. The only way you can ultimately get cost out of the system is to have lower prices and lower utilization. We're going to migrate some from fee-for-service, which I'll talk about in a moment. We are going to be measured, as Dr. Geston said, on both quality and patient satisfaction indicators. And for a state like New York, something like satisfaction indicators or quality indicators may be more challenging. And some of it may be the fact that CMS, in its infinite wisdom, does not recognize socioeconomic factors. So if you're a homeless patient, you're going to be measured on the same quality indicators as if you're somebody who is living in a McMansion. We have yet to talk seriously about what hospital and physician alignments need to be, let alone what our alignments with insurance companies are. We are beginning the discussions around care coordination and patient engagement. How do you extend yourself beyond the four walls of an institution? The data analytics that we use are imperfect at best. We use administrative data sets. We don't use usually real-time clinical data to influence clinical decision-making. We're looking at data retrospectively, sometimes 6 months to a year after the fact. And we don't yet have, as I mentioned before, robust clinical information technology. Getting an order entry system up and going may be great, but that's not really what a clinician needs to work on a day-to-day basis, and it's not what a clinician needs to really react in real time to what information that they're seeing. So we're going to deal with new models of care, standardization of care, and health insurance exchanges. I want to spend a minute on this continuum of payment because obviously this is a key aspect of healthcare reform, and it will impact us significantly as we talk about quality. So we're going from a fee-for-service system, and if you go from left to right across this continuum, we're talking about a number of things that put risk onto the providers, shared risk, if you will. So pay per performance. We'll pay you X, and we'll give you something on top of it, or we'll take something away unless you perform. Penalties for adverse events. Obviously, if you have complications, that's one thing. Now we're talking about readmissions, and whether we argue whether an admission is preventable or not, we're going to get hit on readmissions. And now bundled payments. Can we pay for an episode of care and beyond that episode by paying both the physician and the hospital together in a bundle? Now the bundle, we all can do a bundle great if the normal price for a service is X and we're charging 2X, we can do a bundle terrifically. But when a bundle has to be 0.9X and the physicians in the hospital have to talk about how do you split that 90%, that's when the interesting discussions happen. Accountable care organizations. Again, this is on the way towards a capitated system. Can you identify payment for primary care and then by virtue of that payment reduce utilization? And obviously those of you who are familiar with capitation, it's a per member per month payment, and the whole goal of a capitated system is to drive down utilization. We're now entering into care continuum and partnerships. We have been mandated to extend ourselves beyond the four walls of the hospital. If you're going to prevent a readmission, no matter how well you do an operation, if you're going to prevent a readmission, you have to extend yourself into the community. You've got to at least make sure that the patient gets home okay, gets their medications all right. If the patient is challenged socioeconomically, you have to make sure that they're placed. If they're challenged by language, you have to put a community health worker in the home to make sure that everything is going well. So doing what you do in the hospital is only one aspect of what ultimately we're going to be measured on. If the patient comes back in through no fault of yours, that's still something that's going to both affect physician and hospital reimbursement. So this idea of disease management programs, health homes, medical homes, it's all designed to basically reduce utilization by extending ourselves beyond the four walls of the hospital. And our quality is going to be measured not just by what happens in the hospital, as I've said before, but what happens after somebody leaves the hospital. There is no question, and this is a busy slide for a reason, that we have to reduce variations in care. And we're going to have to embrace the fact that standardized care initiatives are coming. The old clinical pathways are going to be rejuvenated into saying this is the way we're going to care for a patient with a particular disease, with a particular operation. This is how we're going to do it. And if you as a clinician or we as a hospital vary from that standard, we're going to reduce that variation. And a lot of quality, obviously, is talking about reducing variations in care and reducing the complications associated with care. But if we've gone from a period of individual excellence and individual innovation, we're moving towards a more industrialized approach. We've got to recognize the fact that we've got brilliant clinicians, but the reality is that we're going to produce widgets in the same way. We are going to do operations in the same way. Having somebody do an operation dramatically different than somebody else is probably not going to pass muster as we move forward. Insurance exchanges are worth mentioning because the way these insurance exchanges will run will, I think, determine to a large extent how providers respond in terms of quality initiatives, access initiatives, and cost initiatives. And there are two types of insurance exchanges. There's one that's very passive, and there are ones that are more active. The passive exchanges, like in Utah, basically say, if you're an insurance company, put your product on the market, and patients, consumers can look at it, and they can buy an insurance plan. If it's active, as in Massachusetts, then there are certain limits placed on those insurance plans in terms of cost. There are limits placed in terms of what providers can charge, and there are limits in terms of what the expectations are from the standpoint of a provider and from a consumer. New York State is going through that discussion now. Many states are going through the discussion. The idea that you would not form an exchange, the idea that you might not expand Medicaid, I think my prediction is that that will melt away. This is the discussion about the election. So I think that most states will put exchanges up if they've gotten an extension to do that. If they can't put an exchange up, then the feds will step in and put their own exchange up. Why is the exchange important in terms of quality? Because it's an access issue. It seems to me that you can't deal with quality unless you deal with access. If somebody doesn't have access to care, we all know what happens. They come into an emergency room when they're 200 pounds overweight, having a heart attack, and you've got to do an emergency operation. So access, quality, and cost, clearly the access piece of this was the insurance exchanges and the individual mandate. The implications on health insurance exchanges for us as a provider in New York State is that the uninsured really doesn't change all that much, because we have a lot of undocumented and a lot of illegals. We think that Medicaid will change slightly, that commercial insurance will be reduced some, and that the Medicare population and the health insurance exchanges will make up the rest of that. So the mix of patients within the state, we think, will change. And we think that that's going to dramatically affect what happens on the cost issue and the access issue. So how are we responding to all this? And how does this relate to this particular discussion on quality? We believe that we have to maintain our brand, enhance what we do, and quality is first and foremost for a hospital like ours. That the patient experience, that our innovation have to be there, but the quality, the measurable quality, has to be demonstrably better than others. We also believe we have to transform care, that care coordination, data analytics, and new delivery models are part of what a hospital like ours and all hospitals will have to engage in. We have to grow strategically. We have to align with our physicians. And nowhere is that more important than this discussion today. How can we talk about quality unless our physicians in the hospital are totally integrated and totally aligned? It's not possible. We can mandate anything we want. The slide that you saw on central line infections, I think, illustrates the point on what we can do together when we put our minds to it. That's a lot of hard work. A lot of hard work to reduce central line infections in ICUs and neonatal ICUs, and it requires an intense collaboration. The same thing goes with the NSQIP data. It's easy to say, let's reduce urinary catheter infections. Just try it. It's hard to do. It's hard to measure, it's hard to do, and unless we're all aligned as providers, it's not going to happen. And we have to drive down costs. And you can't drive down costs unless you improve quality. You just can't do it. Hospitals, at least for the foreseeable future, are what's called a low productivity industry. And what that means is you still need one nurse to one patient if they're sick and in an ICU. We haven't moved to the level where one nurse can take care of 10 patients. We need a lot of housekeepers. We need a lot of doctors. We need a lot of nurses. And so labor is not really all that flexible in terms of what we can get out of labor expense. So you're really talking about non-labor expense. And the non-labor expense is dramatically reduced when you improve quality, let alone the effect on human lives. So what I would say to you in closing is that the overall view of a hospital, and I think most hospitals and most providers, whether the community hospitals or academic centers, feel the same way, is the following. We've got to align more tightly with the physicians. We've got to improve quality to reduce our costs. We've got to improve quality to demonstrate superior outcomes, and we're going to be in a cost containment scenario for the next number of years where we're going to be paid less for what we do, and we're going to be held more accountable for what we get. So that's why I think this is such an important conference. It's the nature of the systematic change that we're going through, and I think quality is a core piece of it. Thank you very much.
Thank you very much, Dr. Cohen. It is now my pleasure to introduce Dr. Cliff Coe. Dr. Coe is director of the American College of Surgeons Division of Research and Optimal Patient Care. Dr. Coe is a practicing surgeon. He serves at UCLA, where he's the Robert and Kelly Day Chair of Surgical Outcomes and Professor of Surgery. And Dr. Coe, in the last few years, has led the efforts of the American College of Surgeons on quality and national initiatives. Dr. Coe, thank you very much.
Thank you. Thank you, and good morning. My voice is a little hoarse, and I'm going to cough a little bit. I'm just getting over a cold, but over the next 15 minutes, I'd like to give you an update of NYSQIP and some initiatives that are going through. Just as a start, before I started working at the college, I worked at the RAND Corporation, and it's a think tank and does a lot of different things, but one of the things that they think about is on healthcare, and about all the things that you've heard about from the prior speakers. And my boss, we would have these conversations like, we think about all this stuff, does it really work? And he said, well, why don't you test it out? And this opportunity at the college came to really test out a program to see if we can, at the sharp end, where the rubber hits the road, can we actually improve care and surgery? And it's an ongoing battle, but I'd like to share with you some of the things that we've worked on, some of the things we've learned, and some of the things that we're trying to accomplish. So where NYSQIP began, it actually didn't begin with the college. It began in the VA. And several decades ago, the VA was coming under fire from Congress saying that your mortality rates are too high. Too many people are dying in the VA, and maybe what we should do is we should take all that money and give it to the private sector, send all the patients to get operated on in the private sector. And the VA at that time was very smart because they said, well, our patients, just like a lot of us say right now, our patients are sicker. Our patients in the VA have more liver disease, have more COPD and CHF and diabetes and smoke and all that kind of stuff. And so the VA at that time collected all this data, and they did the risk adjustment to have risk-adjusted mortality rates. And when they saw that, thank you. I have so much water up here now. They found that the rates were not different than the private sector, risk-adjusted. Unadjusted, they were different, but risk-adjusted, it wasn't. They found that actually giving back the data to the surgeons and to the surgery departments was really helpful because for the first time they were getting back data that they actually believed. And that's a theme that has gone through from the prior speakers, and I'll give you some more data about that. They continued to do that, and this is what happened in the VA. They decreased their mortality rates by almost 30%. They decreased their complications, their utilization, length of stay, and even patient satisfaction improved. It worked so well in the VA at that time, it was the only place that was getting surgery really measured at a system level or a national level that the next step was that ARC was kind enough to fund a project for the college to see if NYSQIP could be transitioned from the VA into the private sector. It works so well in the VA, can we do it in the private sector? Clearly, all of us that have worked in both settings realize that the private sector is a little different than the VA, or a lot different than the VA. But this study, over the course of 3 or 4 years, showed that we could do it. And we were able to get risk-adjusted clinical outcomes. And in October of 2004 is when we released, for the first time, ACS NYSQIP, so NYSQIP for the private sector. Now we have, when we started in 2004, we started with 30 hospitals. We called all our friends, and they joined. Now we're above 500 hospitals. We're in most states in the U.S. If anyone is here from Nevada or North Dakota, we'll give it to you for almost free. Dr. Hoyt is here, and he can sign off on that. We know that in the world, we are getting so many folks asking us if they can do it, and we're putting things into Africa, into Asia, and we have hospitals in Europe and Australia and whatnot. And so it's a system that makes sense for surgeons to get back data of what we're doing. This is a very simple model. I know that earlier that we're talking about a lot of different models of education and healthcare and whatnot, but this is our very simple model. I'm just a colon surgeon, so this has to be a very simple model. We want to start off and we want to get high quality care. That's what we all are striving for. We want to collect data to see if we're giving high quality care. We do a lot of high level analyses, a lot of things that I won't get into, but we mostly focus on risk-adjusted outcomes. We do some process, we do some structural things, but it's really at the end of the day outcomes. For the surgeons in the room, we do this every week in our M&M conference. We stand up here and say, this is Mrs. whatever. She had a colon operation and she had an SSI and eviscerated and had renal failure or whatnot. We go based on outcomes. And then we look backwards. Well, how could that have been prevented if another Mrs. Smith comes in? How could we have done a better job with that? So we start off with the end result, the outcomes. Once we collect all that data, once we analyze it, and once we package it up, we feed it back. We feed it back to the providers because that's clearly important. Without any data, we all think we're doing great. With data, sometimes it's very eye-opening to us. And then once we get the data back, it involves planning and quality improvement planning. And as the prior speakers have said, it is not easy. It is not, we have enough trouble doing process like getting everyone to wash their hands or give antibiotics. But fixing an outcome is a lot more difficult, and we've shown that, we've seen that over and over again, and I'm sure if you all have tried to fix outcomes, it's not easy, and it takes a lot of planning. It also takes a lot of other things, guidelines, tools, teamwork, standards, and things like that. And when these things come into play and the right mixture is put into that, we can achieve high quality care. Over the next now about 10 minutes, I'm going to talk to you about these components, something about data, something about feedback, something about guidelines and tools, and then some high-quality surgical care. There is really a need for good data. We have this problem of when we have bad data, nobody believes it, and then everyone leaves the room. Everyone leaves the room even if you serve a really good meal. This is what we do in NYSQIP. We have the data collected by trained people. We train them and we test them. We give them a yearly credentialing test to make sure that they understand the definitions, to understand the nuances of these things, and we are very focused and perseverate on achieving good data. And these are just examples of some of the modules that people look at. At the back end, we take the data and we visit hospitals and we audit the data to make sure at the end of the day that the data are good. We want the percent disagreement to be very low against a gold standard, and it has to be 5% or less, otherwise we don't use that hospital's data, and we can't give them back reports because we don't believe it. Risk adjustment is clearly important. As you can see on your left side, that's a ranking by unadjusted data. And on the right side is a ranking by adjusted data. And you can see in orange on the left side, a hospital ranks at 37 and unadjusted does very poorly. But if you probably take into account the patients that they're doing, the procedures that are happening, that their rank changes. And so this is why risk adjustment is very important. Now, excuse me, we just completed a study with CMS where we took over 100,000 patients, where we had NYSQIP data by trained abstractor, audited data, definitions or whatnot. And CMS gave us their claims data. So we had all of their CMS data. And this was on a contract with CMS, and they wanted us to do this. And we compared this clinical data with their claims data. And what we found a lot of things, but one of the biggest surprising things was the percent of complications recorded in administrative data that were false positives. So I'll share the results with you right here. So these are the amount of false positive data for these complications that are very important to us as surgeons: SSI, UTI, pneumonia, or DVT and myocardial infarction. What this means is that if you take 100 patients in a claims data set in Medicare, in whatever, your Sparks that you use here in New York, take 100 patients that have SSI, we found that 58% of them did not actually have SSI. That's the false positive rate. And it comes down to coding, it comes down to definitions, and it's different definitions, and the coders are probably doing a good job, and that's what they're supposed to do, but it really opens up the question of what data should be used for quality improvement. We want something accurate. We want to be working on the patients that have problems, and if we have 58% false positive rate for claims data, that's a problem. Clearly, if we rank then hospitals, and there's a lot of hospital rankings. You go onto Google and you find a whole bunch of these things. If we rank hospitals based on claims data, which a lot of things do, or if we rank hospitals based on clinical data, they do not match. There's very, very poor agreement, and this is the kappa value. If you're into statistics, it's a weighted kappa, but there's very poor agreement amongst that. And so it's very important as we look at these rankings of how we're doing as a hospital or a state or an individual to know what the source of data are and how that works. To the second point of data feedback, one of the problems is that we wait for data, and if we, that teachable moment might be gone if we're waiting 6 months or a year or whatnot. We're working very hard in NYSQIP to have real-time risk-adjusted data. So as soon as that data collector puts in that data, for our measures, that they can push the button and get real-time risk-adjusted data. This is not for all the QI people in the audience. This is not a process control chart where you get an unadjusted rate of, we had 3 infections last month and whatnot, and doesn't take into account their comorbidities. These are real-time risk-adjusted data. This is what the hospitals have said that is really important to have. This was developed, and now hospitals are really using these things to affect improvement. This graph is, we call a caterpillar graph, and this is probably the most important graph that we have in NYSQIP. Basically, all these lines, up and down lines, are hospitals. The hospitals in red are the hospitals that are above the line, and it's kind of like golf. They're shooting above par. They're shooting bogey golf, and they need improvement. The hospitals in green are shooting better than par. They're shooting birdie golf. And they're better than expected. And the ones in gray are shooting par. This single graph, when a hospital says, all right, how are we doing in whatever, SSI or UTI or whatnot, is very powerful because they see that, all right, if we're in red, oh my God, we got to get better. Even if they're in gray, they say, well, that's good, we're as expected, but there are those hospitals in green that are doing better than expected. Who are those hospitals? What are they doing? How can we get there? This single graph is very motivational in terms of hospitals getting better. To the third point of tools, we know that once a hospital figures out that they want to get better and they get people together and like, we got to get better, how do we get better? We put up together a lot of guidelines and a lot of tools and SSI, UTI, or whatnot. One of the areas that we're all facing are elderly. Because operating on an elderly is not the same as operating on a non-elderly. There are a lot of additional issues to take care of. This is our latest guideline, and if you happen to be somebody who takes care of elderly patients, you might want to look at this guideline. It's on, it's on our website, or it's in JACS if you get JACS. But it identifies the important things that we should see or recognize before we take the patient to the operating room: polypharmacy, the risk of delirium, malnutrition, things like that, and what we need to really be thinking, not just, where's their colon, can I do this lap or open, is this, what are my resection boundaries or whatnot, not just the operative stuff, but really the full patient stuff. Another tool we've been able to develop from NYSQIP and the data is a predictive tool. And this is meant to be used ahead of time, and it's a preoperative tool of a risk calculator. So we know what are the important factors in predicting risk, because that's the same thing we do for risk adjustment. And so if we say, let's say I'm going to do a 44140, which is a colon resection, and we have a patient who's 65 and is relatively thin with a BMI of 25. we can generate this predictive chart where we have mortality, serious complications, and all complications. We can look at a low-risk patient and a high-risk patient at the 25th and 75th percentile, respectively, and then we can see my patient. And we've taken this we've piloted this with a lot of people. I piloted this, and it's really helpful because we can now start to talk to patients with what their risk is. I know that when I read the colorectal textbooks, the risk of a leak is 4%, unless it's below the peritoneal reflection, it's 8% or whatnot. But it depends. Depends on the patient's characteristics. Do they have diabetes? Are they on steroids? Are they, what's their functional status or whatnot? This gets it down to the individual patient. This really helps, not just in this patient, but in this patient, where the patient might be 80 and might have a BMI of 30 and suddenly has all of these things. And when the risk goes up like this is a definitely different conversation that we have preoperatively, and it's important for the patient to know that. Get your affairs in order. And it's important for me to know that, like, all right, get the ICU ready, get cardiology ready and the renal people on ready or whatnot. And so knowing this beforehand, other than just, doing that calculation in our head, but really with objective data is something that is going to be important for us to do more and more. If we finish that loop to high-quality care, Dr. Hoyt showed you how hospitals improve. Not all hospitals improve. It's not an infomercial, buy it and you get 2 of them and everyone gets better, but most hospitals improve. But these are the hospitals that are really joining and trying to improve. What's really interesting is this, is that if you look at the hospitals in red here, these are the hospitals that are shooting bogey golf. They need improvement. And the hospitals in green are the ones that are shooting birdie golf. They're better than expected. If you look at, and we did this study a few years ago, and this is for complications. If you look at the next year, most of the hospitals that were below average got better. Not as many as of the good hospitals. But if you bring it out a couple years, most of these hospitals got better, whether they're below the curve or above the line. And this shows us that all hospitals have something to work on and can get better, regardless of where they are on that curve. And we look at, behind the scenes at the college, we look at, is there a hospital that's great in everything? Clearly not. Is there a hospital that can maintain being great at everything? No. And so this is always something that really needs to be worked on all the time. That's both for complications and mortality as well. As we worked on these things, and we've worked with CMS, we've developed measures with CMS, put them through NQF. We've really showed them what we've done with our registry, with NYSQIP, and we have a number of other registries in the college. But CMS really believes registries are a good thing. If you read the Federal Register, which some of you might, but it's basically the instruction sheet of CMS. And if you look, I don't know, maybe on page 51,000, they talk about registries. And basically, they believe that registries, participating in a registry demonstrates a commitment to improve. Not only do they say that, but really for year 2014, it's going to come with a payment determination. So they're putting money where their mouth is because they really believe that this is the right thing to do. We're also working with them on public reporting. Now, some people, don't like public reporting, but it's here. You go to Google again and you see all these public reports. And the feeling of the college and of NYSQIP is that if we're going to publicly report, we might as well do it with the best data that we have. And I'm not saying that NYSQIP is the best data that we have, but it's very rigorous. And so we have a pilot program on public reporting. And if you look and it's with Hospital Compare, the CMS website. And if you look at this here, it just basically says that in October 2012, hospitals in NYSQIP can voluntarily public report 3 measures. And so as of last month, the report came out, and this is what it is. And you can see that, for example, this is the measure on elderly care, that there are hospitals participating in this. And there are hospitals participating and sharing their data if they're above the curve or average, and even some hospitals below the curve. We talk to these hospitals. You're voluntarily, why you're shooting bogey golf? Are you sure you want to do that? And we talked to the C-suite folks, and they said, yes, this is our accountability. This is our responsibility. We believe that this is the right thing to do. We're not happy we're shooting bogey golf, and we will perseverate on getting better, but we believe this is the right thing to do. So it was a very telling and illuminating discussion we've had with these folks. I'm going to end here with some next steps for this program, and recognizing this is a very quick summary. One thing that that has been mentioned previously is improved data collection with EHRs. We know clinical data are better, but it's very burdensome to collect. If we can do it more efficiently with EHRs, and we've had discussions with folks, Epic and Cerner and whatnot, if we can put those things and get some of that data directly from the EHR, good data. We don't want bad data quicker, we want good data quicker. And there is some thought that has to be put into that, but doing that more efficiently is better. In addition to addressing, and this was also stated earlier, in addition to improving quality, we also have to improve efficiency and resource use. We know that in the back rooms of the college, we look at, for example, procedures where there's no complication at all. And you'd expect efficiency to be similar. There's still huge variation in efficiency, even when there's no complication and even when we risk adjust. We can get better in terms of efficiency and things like that. Continued partnership with regulatory agencies, where I talked about CMS, we work with CDC in terms of SSI reporting. Continue the foundation, provide a foundation for investigation. We need to continue discovery. We need to figure out how comparative effectiveness of one versus the other or whatnot can be done, and this registry really provides a foundation for that. Share successes and lessons and potentially developing standards. We have 500 hospitals as our group that tells us this is what worked, this is what worked, this is what worked, and if it works in all these, maybe it's going to work for something else. And if we say that, all right, this has worked for these hospitals, and we share that, that's going to be, that people don't have to reinvent the wheel to do that. The first speaker talked about quality and in the training, and we're developing reports. So this is an academic institution that one of the missions is training and education. We're developing reports for residents. So residents in surgery can get a report, a NYSQIP report of how they're doing and what their complications were and risk adjusted. Because it's important that we train our next generation, not just how to take out the gallbladder or do an API, but within the context of what we're doing in quality. Finally, one of the things that kind of eludes us but is crucial is culture. When we see the hospitals that really improve, these hospitals have this it factor, this culture, and it eludes us. And people, there's all these sayings, culture eats strategy for lunch every day and all kinds of things like that. But it is really culture and teamwork and alignment and all of these things that really will set apart those hospitals that we see. And we're just bystanders that are just watching. That these are the hospitals that get better. These are the hospitals that get better and maintain that improvement. Not just the cheerleading for 1 month on this project. You show a blip and then you move on to something else and then that thing falls down. But really sustained, maintained improvement. It takes this it factor of this culture. And however we can do that to attain that would be a huge goal that we all need to achieve. So I'm going to end here. Thank you very much for your attention.
Thank you very much, Dr. Coe. Now pleased to introduce Dr. Alphonse Pomp. Dr. Pomp is the Leon Hirsch Professor of Surgery at Weill Cornell Medical College and is the chief of the laparoscopic and minimal invasive service in our department. He also is vice chair of our department and is in charge of quality and quality improvement programs in the Department of Surgery. Dr. Pomp.
Thank you. So, thank you, Dr. Michelasi, for putting me fifth after a whole bunch of people, and right after I have this nice contaminated mic. Thank you. Also, if we're talking about also if we're talking about golfers, the people before was a pro tour, and I'm just a weekend duffer. But I'm here to talk about more on the local level, what we're doing here, as far as quality improvement and how we're using NSQIP and how we try to improve and instill a different kind of culture. At the Department of Surgery here, in the aegis of quality and patient safety, we're talking about, and previous speakers have mentioned that we do have weekly M&M conferences. We use a home database which is based on our electronic patient medical records. All complications are reviewed. Not all complications are presented, but all complications are reviewed by the quality committee. And we do have departmental quality reports, and we use NSQIP to go back and validate our own internal quality monitoring basis. We also have a MERS, which is a anonymous, if you wish, medical event reporting system available to anyone who works in the hospital, can report patient safety events, and of course patients themselves, if they find an issue, can report to patient services. We also use the house staff, and they have a quality council, and this is part of the teaching, as Dean Glimsher mentioned, for medical students. It's now part of the resident training process, that there is a process for improvement in learning. And the point that we want to instill in this hospital and this department is that there are systems errors. Of course, there will always be individual practitioners who have errors, but we want to instill a culture change, that this is not a blame, that we want to make it better for the next time around, as Cliff mentioned, that Mrs. Smith comes in the next time. What is eComp? It is an in-house data collection system that logs all admissions, consult cases, and this is logged on a weekly basis. It is an excellent tool for tracking complications as well as monitoring intervention. The logging is performed by one resident per service, and the pros in this is obviously that it captures cases from all clinical services. The cons is that any database is only as good as the people that enter the database, be it an abstractor for NSQIP or a resident for or in-house eComp. To give you an idea, this is the Q2 and Q3 case numbers for this year. So we have from April to June and then July to September. The Department of Surgery does about 1,800 to 2,000 cases per quarter. The quarter case here and the third is the summer vacation. And then we have 4 colored services on the blue, green, red, and yellow, and then we have the other diverse services, and we can measure the total number of cases. When we look at the total number of complications, and when you're in one of these meetings, it seems that all we report on is complications. Most patients don't have a complication. Most patients come into this hospital sick and go home better, and the vast majority of them do. But some of them don't, and some of them don't just because they're sick. But some of them do because they have avoidable or complications that we can improve on. The number of complications is fairly constant over the 5 years that I've been doing this. The morbidity rate as well, and the mortality rate as well. This is a meeting sponsored by the American College of Surgeons, and we are going to look a little bit at what we did comparing certain results and how we use these results to improve the process and the care of patients. So the report period that NSQIP will give us here, the latest report is January 1st to December 31st, and it's based on a huge number of cases that have been extracted. This includes general and vascular surgery cases only. It excludes transplant and trauma. And in this big database, about 1,500 cases from our hospital were referred. This is almost 1,400 general surgery cases, and we were able to take out of those general surgery cases about 200 colorectal cases and about 160 vascular surgical cases. This is a non-caterpillar graph, but it looks at specific problems or issues or good points. I guess we can start with the glass half full on what we're looking at. And the first thing on the left of your screen is that the mortality rate in this hospital is below average, and we are a high outlier. Unfortunately, when we went over and congratulated ourselves, we looked at the morbidity, and we are a higher outlier for morbidities. Breaking that down and differentiating between cardiac, lung, or pneumonia problems and DVTs, we were excellent, but we had 2 outlier performance problems, one with UTIs and one with surgical site infections. So we drilled down on that a little bit, and we looked, for example, in colorectal surgery, where mortality was where it should be expected, but there was a high outlier in surgical site infections. When you look at the attributable costs of nosocomial infections, the data is pretty difficult to interpret, and some of the data is actually a bit dated. But when you look at wound infections and the cost relative to what it impacts on the hospital's bottom financial line, it's substantial. Urinary tract infections do not cost a lot, but they represent about 30% of infections, and like McDonald's hamburgers, they're not very expensive, but they do sell a lot of them, so cost adds up. I'm here not to talk about catheter-associated bloodstream infections or pneumonia. I'm just going to focus a little bit on wound infections. We figured, according to the Institute of Health, we would pick out the two outliers. And we started working on a surgical site infection. Obviously, all improvement processes rely on the exchange of information and using that to educate. And we started prepping patients with chlorhexidine skin prep, which was not our standard, in spite of the fact that this has been validated scientifically for almost a decade now. We used previously quarterly reports to educate attendings and resident staff as to appropriate prophylactic antibiotic choice according to SCIP data. It needed to be administered at the right time. The dose needed to be repeated as necessary, and we did not want excessive duration. We needed to document this in an operative report. That was more difficult, and anesthesia stepped up because they needed to document this in the appropriate fashion. And we measured this as part of the SCIP data, so we were able to validate not only going through NSQIP, but also the hospital follow SCIP data. And when we had individual outliers, these MDs were made aware on a personal basis, not on a public basis, and to improve that. For example, if you look at quarters here in 2011, the first quarter of 2012, after we received the reports of the surgical site infection, by educating the MDs, and they're all numbers here, their improvement went from to 100%. And the good news for the most recent quarter is that the surgical site infection rate with this process did improve. So the previous reporting period was almost 5%. We have that infection rate, and we now are in line with comparable institutions. As Cliff mentioned, this is not our goal on the Caterpillar. We don't want to shoot par. We want to be below par. So we're not going to give up on this quality improvement process. And we then continued to look at catheter-associated urinary tract infections and drilled this down into 2 points that we wanted to look at. Is the Foley catheter duration too long? And patients failing void trial, what do we actually do about them? So we looked at quarter one in 2012, and there were 17 UTI events reported, and 545 patients sampled for NSQIP. Half were male, so we thought in the beginning that there would be a preponderance of males in this, but it's actually half-half. But the majority of patients were greater than 60 years old. A few years ago I would have said elderly, but as I approach 60, I'm saying that they were just greater than 60 years old. About 1/3 of them had urinary catheters placed multiple times during their hospitalization, and most of the time when this was done, this was due to failed void trials. But to our chagrin, almost 80% of these patients had catheters in place for greater than 48 hours. And when we looked at procedure type, they spanned all types of general surgery operations, from colon resection to even breast surgery. We do keep catheters too long, and we realized that 80% of the patients had catheters in place for greater than 48 hours. And all colon-related UTIs, as well as small bowels, were associated with Foley's for greater than 48 hours. And then again, 1/3 of these patients had catheters placed on multiple tries. So when we actually broke it down, there are reasons to keep a catheter in. That doesn't mean that every catheter needs to be removed. And if you have technical issues, low pelvic surgery, or an unstable patient from the hemodynamic process, those catheters probably, we can't deal with that. But to our surprise, there was almost a third of the patients, or a little bit over the third of the patients with catheters in place. We didn't really have a technical factor or any reason to keep those catheters in. And another sort of quarter to a third of patients had a retention, so we were trying to take the catheter out, but we didn't have a good, robust system in place to do what happened when they failed void trials. One of the reasons when we looked down was that these catheters were being arbitrarily kept in patients who had epidural catheters for epidural analgesia. So we were making these patients more comfortable in the postoperative period, as is something that we want to do, but we were keeping the catheters in just arbitrarily. And patients with epidural pain catheters who do not require precise urine output for hemodynamic instability may have their Foley catheters removed within 48 hours of the operation. So we changed this. But again, we had to rule out that patients with very low epidurals for pelvic dissection or a history of urinary retention were not necessarily good candidates to remove them. We actually established a task force. The hospital obviously was very interested in this as well. And using the House Staff Quality Council, we looked down and said, what can we do? And we actually educated the operating room nurses as well in this. So every catheter insertion now gets a question, why are we putting this urinary catheter in this patient, particularly if the patient has an operation that's going to have a less than 2 hours duration. We looked at who was putting the catheters in as well, and although the medical students loved doing this type of procedure, the learning for the medical students was not optimal. So we established, as Dean Glimsher mentioned, a program to teach students how to put the catheters in the SAIL lab, so they weren't actually practicing on people or patients. And then once they learned the procedures, they were closely monitored by attendings or trained house staff. We did need to identify high-risk UTI patients, and curiously enough, females have a higher risk of UTIs and certain, as you can read on the slide, other patients. So when patients do retain urine after and they do not void, we now use a bladder scan. And you can follow the algorithm there. If they are not peeing and they're not peeing because they're adequately fluid resuscitated, we'll just repeat it in 4 hours. If not, we do an in-out catheterization, and we will repeat the in-out catheterization because there's good literature that says taking a catheter and putting it in and out while being uncomfortable has a certain advantage into decreasing urinary tract infections. However, if you persist with a high residue, you're going to keep a Foley anyways. We needed to continue to educate the attending house staff about this, and we went and looked at our MDs. I apologize that the font on the 2 slides and the quarters is different, but we added, we figured out that we needed to add more attendings to our evaluation process. And you can see that the attendings, as Cliff pointed out, they get better if you teach them and you show them. So once you get the appropriate documentation and get everybody on board, everybody approved. Of course, MD9 slipped. So going forward, we continue to use NSQIP to monitor our progress. We're continuing efforts towards improvement of surgical site infections, as I mentioned before. One issue that has come to light is that although the surgeon stays during the entire operation, there's often quite a turnover, especially towards the end of the day, from the anesthesia side, and as they are giving the antibiotics, and that may not be the primary concern of a surgeon who's deep in a pelvis with a lot of bleeding, we need to appropriately redose the antibiotics during the case. And we're starting to look a little bit closer at hypothermia and how to apply appropriate warming. We need to pay particular attention to sterile technique when placing urinary catheters. This is an ongoing process as the medical staff, particularly the medical students who are involved in that, turnover on a regular basis. We need to educate all attendings over and over again that you can remove these catheters on post-op day 1 or 2. We have surgical fellows who rotate through on certain services. And we want to favor in-out catheterization over replacement of Foley to limit catheter duration, but we're getting a little bit of pushback from patients who are said, you've put it in twice, how many more times are you going to put this catheter in me? You can imagine. The bottom line with quality improvement here, and I've gone a little bit quicker to make up for a little bit of time, but I've still gone over time. It's all about the patients. We talk about quality improvement, but there are people that we deal with, and we want them to come in and get better and not make them worse in any way. Change can start anywhere. The top is a good place to start. We have excellent buy-in from Dr. Michelasi, who has been very much involved with this process. And the residents play an amazing role in the teaching hospital, and if they're not on board, we really don't have a good way to improve things. Two administrative chiefs, Dr. Cervais and Dr. Bott, I'm beholden to them for some of the slides and the data here, or NISQIP abstractor Teresa Frey and Carol Gelman, who works from the hospital with me in the quality process. I couldn't do these slides without them, and of course the group from ECOM. Thank you very much, and we look forward to the rest of the discussion.
I just want to take this opportunity again to congratulate you. I think what you've heard is really what can happen, particularly in one institution when there's alignment of leadership. And I really want to congratulate you all at New York Presbyterian Hospital and Weill Cornell Medical School. We are at a crossroads with quality, and Dr. Corwin really mentioned this in saying that, you know, as of a year ago, we were looking at a potential election that might change our commitment to how healthcare reform occurred. We were looking at Supreme Court decisions. That's now behind us. And in fact, many of these decisions have been put forth. And in fact, there are going to be regulatory initiatives, if for no other reason, that come about that are going to start to incent value-based purchasing, participation, et cetera. At the college, though, and really in the comments that Dr. Glimpture made about sort of what is our responsibility to students, Cliff mentioned this as well. It comes down to a cultural and a commitment that's oftentimes hard to define, but I think really is the reason all of us that are physicians or nurses went to professional school in the first place. It's about the commitment we have to our patients. So in fulfilling that public trust, I want to just end with a little video before we get into the panel that really tries to take this concept of committing to quality to the next level and really emphasize what's behind it and the fact that we're really just driven by it because we're professionals.
So, as we move along, and next time I'll have to offer a little coffee break in this as we sort of stretch our legs. Does everybody just want to stretch up for one moment so that we don't get blood clots, but you're not allowed to leave the room? All right, just sort of stretch up and wake up a bit. We're moving into the second part. Yeah, that feels good. All right, we're moving into the second part of this morning's conference, and I think in order to sort of take a more personalized approach, a few very distinguished panelists have been invited to present their particular views on the Surgical Healthcare Equality Forum here. And just in order of appearance, the first panelist will be Dr. Leon Pachter, who in New York really doesn't need much of an introduction. I'd like to personally thank Dr. Pachter and appreciate his commitment. As all of you from New York know, NYU is very, very severely impacted in a negative way by Sandy, and I'm sure he's extremely busy as 3 of his institutions are closed, and he's scrambling to provide optimal patient care. I suppose that will be the subject of another talk in the future. And without further ado, Dr. Pachter, the chairman of the NYU School of Medicine, Department of Surgery, is going to talk to you a little about dashboard metrics and how you make it better at your house.
Yes. First of all, I would just like to say that while our heads have been bloodied, we're not bowed, and despite the fact that we're running on fumes, I can assure everyone that we're going to land safely. This certainly has been a challenge. The purpose of this forum here today is obviously to deliver quality care, but reduce the cost. And as Dr. Geston said, there is a disparity between spending more money and outcomes. In fact, we spend a lot of money, but our outcomes are less or worse than some third world countries. Just by comparison, the amount of money that we spend in health care equals the entire gross national product of France. Now, you have to sit back and think about that for a moment. So we at NYU, as other places, have tried to do this, deliver quality care, at the same time lower costs, and look at it in a very objective fashion. Now, this is the story. That's why we need data. You know, how big was that fish you caught? And then you see the guy on the right side. It's this big, it's this big, it's this big. It's like asking a surgeon, how many Whipples did you do? Oh, I've done 120. Well, let's look at the data. Oh, you really did only 20, not 120. So without having the data there itself, people try to have a fuzzy, view of what reality really is. Now, the dashboard metrics, this was brought to bear by Dr. Robert Grossman, who was both the dean and the CEO, and he conceived this dashboard metrics. Sometimes I feel it's like 1984 when I go to the bathroom. I wonder, is he actually looking at me? Because he knows every bit of data of every surgeon, of every doctor in the hospital. So our hospital uses this unique management dashboard which provides quality data on mortality, 30-day readmissions, surgical site infections, length of stay, discharge before noon. Many of these things the previous speakers have addressed. This has been a useful tool to objectively determine trends, verify the data, and I would stress verify the data, and provide feedback to individual surgeons in a private manner, including how they match up against their peers for equivalent procedures. This is outside of the NYP-Weill. This is purely internal. Now, again, it's the basis for accountability and transparency. It's an excellent tool for quality improvement and determining trends. And the data can be sorted by patient, physician, and division. So you can compare each surgeon within his or her division to everybody else in that division. And then you can look at it as a complete departmental. Length of stay is measured, infection rates, including surgical site infections, septic shock, and then this quasi figure, which is called overall infections. And I would stress to everyone here is that when you're going to look at this data, be sure to have someone on the physician end following up on this, because what we discovered is that anything ending in itis was coded out as an infection. So dermatitis was coded out as an infection. And I would also stress to you in terms of the house staff of the students, if they put a note in the chart saying the wound is erythematous, rule out infection, well, that's going to be an infection until there's a note saying that there is no infection based on cultures, et cetera, et cetera. But unless you do that, it's the coders are going to put that out as an infection. This is then going to be reported to the state. Mortality, observed versus expected, and another one about discharges before noon, because this has a serious impact on length of stay. Because you hold off those patients on the discharge, then the length of stay increases, especially on the weekends. So I would, tell every one of you, take a look at the weekends to see when are patients are discharged. How many patients are actually discharged on Saturday or Sunday, or are they waiting for the attending who doesn't come in, say, well, we're not going to discharge that patient until the attending comes in. Well, the attending is going to come in on Monday, but the patient could have been discharged on Saturday. So you need to look at that. And the next thing is patient satisfaction. Dr. Coe, or maybe others, can tell you that this is going to be a metric by CMS to the extent of, I think, about 1%. And they will deduct that. But there's a disparity, once again, between someone who's homeless and someone who's not homeless. Recently, we had a patient that was in a hospital, and the patient, she was completely dissatisfied with the hospital. Why was she dissatisfied? She's the wife of a big executive, and she was dissatisfied because the coffee that was brought to her was not in China. She wanted coffee to be brought in China, but that doesn't really come out in the questionnaire. It's a dissatisfaction with hospital, amenities, et cetera. So if you cut off 1% from the hospital reimbursement by CMS, that's real money. So this is just an example of the metric that we have here, and let me look at this pointer here. Does this work? No. Okay, so right here is the mark that we're shooting for, and as you can see here, this analyzes this by quarters, and every time we look at this, if we're above this line, the dean and CEO will call me and say, okay, Leon, why don't you explain to me why you are above this line? And then when we bring this down here, I must say that the goalpost starts to change. And you'll see in later ones, the dean will come back to me and say, okay, this line is no longer here. It's now down here. So you do a little better. Over here, what you see, these blips here, these are individual surgeons. And I'm not going to mention them by name. I'm not going to show them. But when you click on each one of these, it tells you who the surgeon is. So I can look at this and say, well, Surgeon X is above this line. I can see which cases, he was above this line or she was above this line for. And then I have created committees for each one of the metrics headed by a surgeon, who then will send a note and call up and say, okay, Dr. X, you tell me why this patient was here longer. Let me know about that. So it's not in a vacuum. You need to have an explanation, and this is accountability. Because once the surgeons start knowing that someone is actually looking at them and asking, what's going on here, and you have to give a cogent explanation, believe me, they change their attitudes. So here are some of the other metrics once again. This is length of stay, and this is the target here. This is that's not mortality. This is the mortality observed over expected. And you can see that in this quarter, it was pretty high. But with looking at everything here, we dropped the mortality right down to here. Now, you say, well, how do you do that? Well, I tell you, a lot of this also has to do with paying attention to some of the data. When I looked at the UH Consortium data on liver transplants, I was completely shocked because collectively there were 620 liver transplants done without a single death. That's not possible. That's absolutely not possible. So I investigated this further. So what happens is that they see somebody who's not doing well, the patient gets then transferred to a hotel or a facility outside, or they get put on palliative care, okay? Once they get put on palliative care, they no longer is a mortality, okay? So these are a lot of games that are being played. I'm not saying that people should play games, but if you're going to start reporting data, you need to know what are the rules of engagement. The bottom line here also is this 30-day readmission. Now, one of the things that provided in this folder that everyone here has gotten is the article from JACS on 30-day readmission. And 70% of surgical 30-day readmissions are due to medical problems. They're not due to surgical. But of the others, of the surgical problems, there are serious issues, most of which are infectious in nature. I mean, I've had patients that have been discharged and had some chest pain, didn't really need to come to the hospital, but got readmitted. Well, that counts against me. It's the physician of note that is discharged. And I think Dr. Coe may have alluded to this also. When you, for example, you have a cardiac patient, you operate on that patient, then you, let's say we're in New York here, you send them out to a rehab facility in Poughkeepsie, okay? The patient is having either chest pain or have a fever at night. They call the house doctor. The house doctor says, I'm not coming in at night. Why don't you just take that patient into the nearest emergency room? Well, then the patient gets admitted. That's on your account, okay? And that happens a lot. So we need to get control. As Dr. Corwin said, the box now has expanded. It's expanded beyond the hospital. It's expanded to all these other areas because you are responsible for that. That is your patient. You're tagged with it. If you're the discharge physician, you are tagged with that patient. Getting down here, now this is the infection. The blue is septic shock. I've never seen patients in septic shock, maybe once in a while. The green is really what we're concerned about, which is surgical site infection. And this beige is one of these vague things about infection. But nevertheless, we look at each one of them, and I have assigned, again, a physician to look at every one of these metrics, because once the coders send them out, that's gone. It's finished. And even if they were wrong, this cannot be corrected. It has to be corrected before it goes out. Now, CMS and 30-day readmission, this is a serious problem. So in March 2010, the Patient Protection Affordable Care Act was signed into law, and within it was Section 3025, which holds hospitals accountable for 30-day readmission. The hospital reimbursement will be reduced based on expected over-observed 30-day readmission starting in 2015. And if you note, from 2003 to 2004, 19.5% of all Medicare admissions, Medicare beneficiaries' admissions were readmitted within 30 days at a cost of $17.4 billion. Major bowel resection, 16.6% readmitted for GI problems, with only 6.4% admitted with infections. Coronary artery bypass, you can see here, 16.9% secondary to infections. Whipple operations had the same numbers. The readmission for general surgery patients, again, is multifactorial. However, post-op complications drive the readmission rate. Now, this is an example of how we use this. This is a patient that had a laparoscopic ventral hernia, incisional hernia repair with Marlex mesh. The patient was readmitted 2 weeks later with abdominal pain and small bowel obstruction. The patient was operated on, and the mesh was incorporated with the bowel, causing the obstruction. So not only was this patient readmitted, the patient required another bowel resection. So how do we use this to educate the surgeon? Well, we're looking at evidence-based data, and we present the surgeon presents this case, and we show him that based on the literature and experimental data, that the mesh that he used was inappropriate, and that if he was going to use it, he can expect a higher rate of complication. Therefore, educating him into using something like super mesh or Paratex is something that he has now learned, and other people have learned that you can put in mesh, Marlex mesh, in the peritoneal cavity, but you're going to run the chance of having the bowel stick to that, 30-day readmit, complications. So now he's educated on using a different type of mesh. So the 30-day readmission rate, you see our highest was in transplantation, and we see in quarter 210 Q3 and how we've improved that, dropping it all the way down to here. It's come up a little bit, but this is direct result of talking to each one of the individual surgeons who had that patient readmitted. Why was this patient readmitted? How could you prevent it? And for the overwhelming number of cases, you actually can prevent that. Now, again, this is the observed, this is the expected mortality rate, and this is our observed mortality rate. Once again, with the dashboard, we were able to look at this and then drop this down by keeping down our complication rate. But it's the objective data that drives this. Without the objective data, you call in one of your surgeons, said, I don't know what you're talking about. You know, show me the data. Oh, this data is faulted. Well, we show him that the data is not faulted. This data has been vetted and has been vetted by one of your peers. So please explain this to us. Now, again, this is the NYU surgical mortality versus the dean's dashboard. Now, you see, this was the line that the dean set for us. This is the bar, and they can see where we were. Actually, when we started doing better, he dropped the bar down to here. Okay, so we said, all right, we can meet the challenge, and we're now down to here to a 0.23. So as we improve, the bar drops, but as the bar drops, then we're decreasing the cost, we're decreasing the length of stay, and we're providing quality care for the patient. Now, you can once again see the length of stay. This was a pediatric, so the dean called me up. This is absurd. He said, look at this. Look at, the surgeon here. How could he possibly have this kind of length of stay? So without really looking into it, you wouldn't know. You say, okay, this guy is a bum. Well, he's not a bum. This is a guy, a surgeon, who accepted 3 pediatric patients from other institutions that were operated on and were reoperated on for TE fistulas, not done well, and these patients stayed in the hospital from 2 to 3 months. Okay? Now, this is something that we're going to have to accept. But without looking at this, and people who are getting this on the insurance and CMS, they look at this without the data. They're saying, no, 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 you guys are not doing something right. Your pediatric surgeons are really bad. And I don't think, and you publish this outside, and the lay public looks at this without really knowing what it is. Say, I don't care if you're a center of excellence. It doesn't matter to me. If your infection rate or your length of stay is this, I'm not having this operation. Oops, sorry. So let me just finish off. I'll finish off. I got the signal for time. So, okay.
I'm sure there'll be the opportunity for questions and discussions to make up for the hook. All of the speakers on the panel have extensive bibliography or introduction in the little handout that you have. Our next speaker is the second panelist, again, in order of presentation, which just happens to be alphabetical, is Jeffrey Peters, who really stepped into giant footprints when he became the Seymour Schwartz Professor and Chairman of the Department of Surgery at the University of Rochester Medical Center. But as a surgeon who does a lot of esophageal and foregut work, he's extremely well known and respected all around the United States and internationally as an esophageal surgeon because he publishes a lot of extremely good data. And he's a former president of August Society of Sages, which is something that I hold dear to my heart as well. And he's going to speak to us a little bit about NYSQIP and how he's dealing with that in Rochester, but not Minneapolis or Minnesota, Rochester.
Thanks, Alphonse. I want to make 2 points. I'm going to share with you about 6 slides of a 6 to 7 year history of experience with the NYSQIP program and an evolution that I think is beginning to come full circle and that we struggle with where to go from here a little bit. But firstly, I'd like to say I'm so proud, and I think, I hope everyone in the room is equally proud that our American College of Surgeons is leading in many ways the national effort towards quality. It is a superb place to start with our Organized Medicine Society, and I thank Fabrizio and Dr. Hoyt and Cliff Coe for the opportunity to come and join this, and I couldn't be more proud to be part of it and part of the college. As you see here, I'm going to tell you a story of 2 different hospitals and illustrate in a real-world sense the point that, the second point that Cliff Coe made when he talked about the importance of communicating the data. This is hospital number 1, which is our mothership hospital, and you can see the data beginning in 2006. The number in 2006 is actually, the N is slightly smaller because it's when we just started. But year after year, it took maybe a year's time to begin to see the fruits of the labor, if you will. And the labor that occurred in this hospital was constant emphasis on the importance of mortality data, and morbidity data was equally emphasized. And feedback to the clinicians every 6 months through a variety of mechanisms, dashboards, as you just heard, and dissemination of the NYSQIP data to virtually all faculty members that were engaged in this. And NYSQIP, as you know, is general vascular and colorectal surgery. And then we saw something that was remarkable, really, and we saw it report period after report period after report period that went on almost 5 years that convinced me that this is a real phenomenon. You can see that this trend here is absolutely believable, and the mortality continued to go down and down. Now this is hospital number 2, and in hospital number 2 it was a different paradigm. In fact, until you see there about in 2010 when I first recognized that there was such a discrepancy between these two hospitals, I realized that the information from NYSQIP wasn't trickling down to the surgeons in hospital number 2. And the shape of the response of, this is mortality again, of the mortality in these two hospitals is quite different. Hospital number 2 has a different culture. It's a smaller hospital than hospital number 1. I don't know the precise reasons for why these two trend lines differ so much, but one of the reasons I'm certain is that the communication and the information feedback back to the surgeons was quite different between these two hospitals. As I mentioned, I didn't even discover until 2010 that the information wasn't trickling down to the surgeons in the second hospital. We started to do that, and you started to see the mortality decrease. There is no question, two things. One is that there is a very prominent Hawthorne effect here. As Dr. Hoyt said, you measure it, you feed it back, and maybe that's 80% of what we need to do, particularly with something as black and white as mortality. It definitely happens without question. And number 2 is, if you don't feed it back, you measure it and you don't feed it back, you don't see the response. I think a fascinating real-world experiment that went on here. Now, so that's first point number 1. Point number 2 is this graph, and if you paid attention to the trend line when I showed it to you the first time, it's the same graph as the first one I showed you. This is hospital number 1. This started to happen. We got better and better and better and better, and I was wondering where it was going to go here, but this started to happen. And that has me concerned. And not only it has me concerned because the mortality is beginning to tick back up again, but it brings to light the fact that we really have almost no science and no understanding of the reasons behind recrudescence or complacency or whatever is the factors that are causing that to happen. And I would challenge the NYSQIP community and the physician community in general to try to begin to understand why that happens, because I'd like to turn it back around. And I don't know quite how to approach it and turn it back around to get it back down. Maybe we should try to reemphasize things again, or a variety of interventions that we can do. But it's beginning to tick back up. And the time frame with which that happens, I think, is also interesting. It's not 12 months. It's not 18 months. This is about 5 years, and then after about 5 years, complacency starts to set in. We've wrung about as much of the easy improvement out of the system, if you will. We picked the low-hanging grapes, and now we see it trickling back up again. And the next couple of slides emphasize the fact that I think this is a generalizable phenomenon. This is the overall mortality in the whole NYSQIP program in our mothership hospital. But in fact, it occurred in all the disciplines, which makes me think that it is a real generalizable phenomenon. Here is vascular surgery, and you can see improvement, 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 and then it ticks back up again. In fact, it ticked back up much higher than I would even that I would like in vascular surgery. It occurred in colorectal surgery, where it went down and down and down and improved, and then it's ticked back up again. And then it also occurred in general surgery, which is the first slide that I show you, where it went down and down and down and then ticked back up again. So I just wanted to share with you that 5 or 6 year experience in both the hospitals that we manage at the University of Rochester, and some of the challenges that I think for the future of how to make sure that the information gets disseminated. And number 2, now understand a little bit what to do when the curve starts to trend back up again. Maybe we can talk about that in the discussion. Thank you very much.
I'm sure that's going to bring up a whole bunch of questions, because I don't think it's necessarily an isolated phenomenon. And I think we can also discuss whether or not what happens when you try and make the improvements and you don't see a result down the line. And that's sort of my segue into the next introduction of the speaker. This is Pierre Saldinger, who had a stellar reputation as a surgeon and a scientist, and this brought him from a state from a country further east and a hospital system further east to our sister institution, New York Hospital, Queens, where he's chairman of the Department of Surgery there. But what brings him to this conference and has a particular interest is he's not only looking at how to deal with NSQIP data on a retrospective basis, but to also look at it in a positive fashion and going forward to, instead of reacting, to proact. So without further ado, Pierre. By the way, he's helping us as well here.
I need some water because I was stricken with Dr. Koh's affliction. I need the same disclaimer. I would like to thank Dr. Hoyt and the American College and Dr. Michelasi for including me in this very important event here. Similar to Dr. Peters, I'd like to report on a 7-year love affair with NSQIP, and more from a philosophical point of view. I think with respect to NSQIP, it is important to realize what it is. And really, it is a tool, an excellent tool. I believe it's probably the best medical database in the world right now. But it's not a solution. So you can't just buy NSQIP and then hope it's going to do its thing. It will provide you, as Dr. Koh said, with actionable and credible data, which is really very important. As surgeons, we don't like to have hallway peer review. Oh, did you hear again? He had another complication, another leak. This kind of comments are not productive. However, it's become clear to me when surgeons are confronted with real and credible data that shows that they are underperforming, they will be the first to want to improve that. It enables continuous performance improvement, and I will elaborate on that in a few minutes. And it also provides a story, not just a picture in time, not just a dashboard over one time. You can tell a story and try to understand the story, which is really important. What NSQIP is not, and I think it is important for hospitals that would like to engage in NSQIP to understand that, it does not equate with performance improvement. Again, it is a tool. It is not the solutions to all your problems. As Dr. Koh has emphasized, much of the changes that you have to engage in to improve the results are linked to culture changes. NSQIP is not going to do that for you. And it is not solely a surgical tool, and I will elaborate on that. You need an integrated, experienced performance improvement team that is multidisciplinary. As previously indicated by Dr. Hoyt, medicine, and in particular surgery, is a team sport, not an individual sport. We have surgeons involved, departments of surgery. We have anesthesia. Someone has to put the patient to sleep after all. You have nursing. You have medicine. So you have, your hospitalists, you have cardiology, renal, ID, pulmonary, etc., that participate in the preoperative assessment and sometimes in the postoperative management of your patients, the ICU environment, information technology, and not to forget the residencies. A few of the speakers have emphasized how you have to include the residents. In fact, the ACGME has a mandate to have what they call bottom-up performance improvement for residents. So you have to include them in your committees and give them little projects to do. And in fact, who's going to enact the performance improvement? If you have residents, it's them. So they are a very powerful tool to have and to include. And in fact, at my previous institution, we did just that. We included them from the beginning, and we just published our experience there as to how to include the residents in NYSQIP and proceed with what I would call early indoctrination. So by the end of their residency, NYSQIP is part of their fabric, which is really important. You include it at every M&M. Every opportunity you have, you do so. You provide them with access to your nurse reviewer, who are valuable resources for the residents as well. So the big fish, and how big was that fish? Many of you will know the news from Lake Wobegon of Garrison Keelers, and you know, where the women are strong, the men are good looking, and in our case, the surgeons are all above average. And you know the same. Certain speakers have pointed out, if you go to a plenary session at the American College, and you would anonymously ask everyone who's above average, most of the surgeons there would consider themselves as above average, and we know that statistically that is not possible. So we have to counteract that and confront them with the fact that the fish that they fished maybe wasn't this big. And that needs to be in a positive, constructive way and not in a punitive way. So what we started doing, in addition to have the biannual report, is to generate quarterly reports. So the alert here is not to wait for that biannual risk-adjusted report, but use the data you have in NYSQIP on an ongoing basis. Generate your own reports. They're not going to be risk-adjusted, but they will give you a good feeling for the temperature of the water. It's kind of your canary in the coal mine. So you don't get your biannual report, look at the data and say, oh my God, look what just happened here. But yes, that's a bad result, but we knew about it 6 months ago, and we've already initiated countermeasures. So this is one of those reports we did generate. You see here are the usual suspects that we follow. We listed our incidents over time. You have the trend. We used a benchmark like hospitals and looked at what their incidence was. And here you have good, and red is not so good. Now, when you're an outlier there in your own system, it doesn't mean that something is wrong necessarily, because it may come out in the wash with the risk adjustment. But you might want to look into it. So what you do, you start pulling charts. Why do we have more DVTs now? Look at them. Look, did we comply with best practice in evidence-based medicine in all those cases? Very simple analysis initially. And then if that was the case, look at other factors. And if there's a little bit of a smoking gun there, you're going to investigate. And this is kind of what we do with these cases. It's identify that target, validate that target, do a deep data dive. Really look at, is there something there? You identify the involved services. Again, it's a team sport. Bring them all together. All the people that contribute to that outcome, not just the surgeons, and form a task force, create an action plan, implement, monitor, validate, and then go back. And this is kind of an ongoing loop, similarly to what the CUSP system is, the comprehensive unit-based safety programs that was created at Peter Pronovost at Hopkins, and the American College has now a pilot project with CUSP. We're fortunate to be one of the pilots, where this system is being applied on an ongoing basis. And that is actually your vehicle, if you think about it, for culture change. Because what we're talking about is really changing a culture where we go from individual performance to that team sport. And I said in a meeting of our quality team a few days ago that the OR should not be a place for display of individuality. This is no longer about individuality. This is about complying with evidence-based medicine, best practice, because medicine is no longer an art. We have to come to terms with that. It's a science. And let's apply those principles. Now, I was asked to briefly talk about the Connecticut Surgical Quality Collaborative. Dr. Sanchez is here, who was one of the partners in crime to create that. It was under the auspices of the American College of Surgeons, the local chapter. And in essence, it started with a few surgical chairs, surgeon champions, and nurse reviewers sitting together saying, hey, we all suffer from the same problems. Let's tackle them together. And ultimately, you start merging your data, look at it together, and really start learning from each other. We have best practices that apply generally, but there is always a local, regional kind of flavor to things. And when you get together, you can really start talking about this. Now, You need to overcome competition. The hospitals usually sitting together are competitors. You need to have a pledge to say you're not going to use that data once you walk out of the meeting going like, whew, these guys, across the street, man, the results they have, that's really horrible. You need to establish a level of trust that ultimately will contribute to better patient outcomes. It is about the patient at that level and really nothing else. And I'd like to close with really a few remarks, which is that NSQIP is really a valuable resource that addresses issues well beyond its original intent. When your nurse reviewer abstracts the charts, they will find a lot of things that have nothing to do with NSQIP, non-compliance with state regulation, JCO, notes that are not signed and date, anything you want. And it's sort of a backdoor audit, continuous audit of your charts. And it really increases your JCO readiness if you listen to that and build a system to debrief your canary in the coal mine and listen every now and then to what's there. Because they'll tell you, you know what, there's been a couple DVTs again and something's not right, and you better listen to that. Again, NSQIP is a tool to assist in surgical performance improvement, but it won't do it for you. And linking NSQIP to the performance improvement team in your hospital, not just being insular within surgery. Anesthesia is a perfect example. There are a lot of variables in NSQIP that pertain to anesthesia. Once you convince them that it's not a bad thing, they'll actually come knocking at your door saying, can you give me a regular report on reintubations and all the indicators that are linked to them? So I think it is very important to apply it very broadly and gain the maximum benefit. Thank you very much.
So, saving the best for last? Maybe, maybe not. I'd like to thank the speakers, previous speakers, for adhering to their time frame. Our last speaker is all the way down from the state capitol. It's Dr. Stain, who has a stellar reputation, having led another surgical department or division and now being the chief up at the Department of Surgery at Albany Medical College and the Henry and Sally Schaefer Chair. He's going to look at a little bit about how to drive NSQIP data and improve hospital processes. And once he's finished, we'll get all the panelists up there, and we look forward to an interactive discussion where you've all been very patient and listening to us. It's going to be your turn to ask us some pertinent questions. Dr. Stain.
Thank you very much, Alphonse. Well, I have a few things I'd like to cover. It shouldn't take very long. I'm going to try and give a couple of clinical scenarios that we've been able to make some changes. I'm going to talk about some of the barriers we've had, the realities of getting this funded, how I fight that budget battle every year, and talk about our overall use as a quality measure. So maybe you've probably not been to Albany. We're a 630-bed hospital, soon to be 700 beds. And about 75% of our admissions are from the full-time faculty. So it is a mixed hospital with community physicians who are academically affiliated. Our vascular surgeons run a fellowship. They teach our residents, teach our medical students, but I don't pay their salaries. So it's sort of more of a convincing than mandating, and I think it's interesting to tell how that has worked with them. So they say they're the largest vascular group in the country. They have 18 surgeons. They have about 8 that are centered at our hospital. Just in our one hospital, we do 1,700 operations per year. And they believe they're the best vascular group in the country with the best outcomes. Their patients, though, they're sicker. The fact that our outcomes may not be so good as I just don't understand that the patients at Cleveland Clinic, New York Presbyterian Hospital, Mass General, they're just not as sick as the hospitals at Albany. So in 2009, I got this result. You see these caterpillar graphs which say that we're a bad outlier for our 30-day morbidity. And the nice thing about NSQIP for us is you can pick out very quickly every one of those cases that you failed in. And my nurse reviewer, Sharon's in the audience, and she would go back to the medical records and pull out the discharge summary, the operative note, and make the vascular surgeons review every one of those cases to see why we were having that problem. And most of our morbidity was cardiac. Our patients were having a disproportionate amount of myocardial infarctions, we were at a loss of why this happened. Every patient, the vascular surgeons get a preoperative cardiology consults, but when we dug down to what was happening, they had the cardiology consult, but the cardiologist never saw him in the hospital again. The patient was being managed by the intern on the floor, and we were able to get some changes in the hospital. First of all, the chief of cardiology, the private cardiology group, the full-time, they all agreed they would follow the patients in the hospital. We got a cardiac anesthesiologist for every major vascular case. We instituted the institution of vascular ICU. We put it in intensive. One of our SICU people is down there every day to help take care of their patients. What we were able to do, and this is over the last 3 years, is see our cardiac complications go from being an outlier to we're still not quite as good as we need to be, but it's been a relatively rapid change. And even though our vascular surgeons who believe they're the best in the world now can at least say we're approaching being like the rest of the world. We have done general and vascular surgery for, I think, 4 or 5 years. And last year, I convinced the hospital to, pay the additional amount necessary, more important, the additional half FT required to do multi-specialty. And that was a big deal for us because we essentially have no quality data for ENT, urology, neurosurgery, all those specialties. And what we found was in gynecology, we were having urinary tract infections. I think one of the previous speakers talked about UTIs. We had physicians who were leaving Foley's in for 3 or 4 days. But the nice thing about what NYSCLIP allows to do to go back to every case and identify every surgeon, number of cases they had that year. So our busiest surgeons, gynecologists, had the highest urinary tract infection rate. And we found those people, this gynecologist, didn't take out their Foley. So we were able to institute a policy in the hospital where the nurses will ask the doctor after 48 hours, Dr. Jones, do you really need to keep that Foley in? And just that simple thing we think is going to pay dividends for us. So I'll just close with a few things about what happens in our institution. So every year we have a budget battle about what the hospital is going to put their resources in, and I think, so this year they've threatened to cut our second person for the multi-specialty. And that's at a time when, I think I just showed you the urinary tract infection rates, which they would never, ever have. That's going to have effect with our CMS payments. Fortunately, some of the insurance companies are reaching to recognize the value. One of our payers, there's 3 hospitals in the Capital District that have NYSCLIP. One of the payers pays, at least for 2, I'm not sure about, so they pay the NYSCLIP fee for the hospital because they get for us quality information that they believe will improve our quality and actually, I believe, will reduce our costs. One of the things I've been able to do in our institution is for other state measures or national measures when we don't look so good in non-risk adjusted measures. The one I think of is Blue Cross wants us to have a 4.5% infection rate for colon surgery. There's never been a prospective trial ever that showed a 4.5% surgical site infection rate for NYSCLIP. It's about 8%. So we've been able to convince Blue Cross that as long as we're below the NYSCLIP average, our ODE ratio, then they will give us the additional money for meeting that standard. So I think the benefit for us for NYSCLIP has been it really allows us institutionally to compare ourselves to national standards and convince physicians, at least our institution, they're really not that special. Thank you very much.
So I'd like to ask the panelists from the last 4 talks to come down, and Cliff, if you can sit there and we might, we're going to quarantine Cliff off to the side. We'll give you a surgical mask, and we're going to ask Dr. Foster Geston to come and speak as well. to sort of start it up, I think there's microphones available in the audience, so if you'd like to ask questions, just raise your hand. I'm going to try and look back and squint against the powerful lights here and see. Maybe we can turn the room lights on 100% up there. Make it nice and bright. No, that's the wrong way. Make the lights brighter, not darker. And if you ask a question, please identify yourself and where you're from. And sort of to lead it off, I think Atal Gawande, someone mentioned Pronovost and Gawande, they're sort of two peas in a pod, but he mentioned that the difference between an academic institution and a community hospital is not the rate of complications, but the rates of saves after a complication. So what he said was once the unexpected outcome happens, the mortality rates are lower in academic institutions overall because they don't have less complications, but they deal with them better. Any truth to that, Cliff?
Is this on? Okay. So we did an evaluation and found that the academic places actually have a slightly, I don't know if it's clinically relevant, but slightly higher complication rate, but a lower mortality rate, which would be consistent with a better rescuing. But, you know, I think that nowadays there's a lot of complex surgery performed in non-academic places, and everyone's going to probably have to get better at rescuing when these things happen.
All right. Okay.
My name is Bill Graber from Syracuse. I have 1,000 questions, but I'll just ask one for this time. We heard about getting things on track and aligned and affiliated and a buy-in, and in my institution we're struggling to get surgeons to get to the OR on time even, much less everything else. And I just need some advice on buy-in of people who've gotten their institutions. I mean, even getting the hospital to pay for NSQIP, I mean, which sounds like a no-brainer to me. That's part of the buy-in. So how do we do this?
So I'm going to let Jeff Peters start, and then I'm going to get Pierre to give his comments. And I'm just picking people at random here, guys. Don't feel personally affronted.
I'll just say two things. One is that, firstly, I think it's a moral imperative. It is a abomination if we allow surgeons to ignore this issue. You know, controlling their behavior in other ways is a different story, but it's an abomination. And then the second thing I'd say is that slide is real. It is real. And once your CFO of the hospital appreciates that it is truth, it's not rhetoric, then it becomes much easier to make this happen.
So the slide, for those of you that are way back there and can't see it, says that NSQIP pays for itself. For those administrators in the audience, NSQIP pays for itself. You had a comment down there, Dr. Pachter?
Yeah, I mean, the solution to your problem not coming on time is very simple. You don't come on time at 7:30, you lose first OR time. And you need to implement that. I mean, I guarantee you the first time you take away the 7:30 time for someone not showing up, they're going to show up on time.
Other questions? There's one there in the corner. Yep.
I'm Chris Sastry from North Shore LHA. One of the things we noticed in this data collection is the calf vein thrombosis is being listed as DVT. So we're looking at this huge spike in DVTs, and as we know, the calf vein thrombosis is not necessarily treated. Is there a way that the NSQIP looks at it as treated DVTs versus non-treated DVTs? And we're also looking at data collection through NSQIP is to get accurate information on perioperative complications is sometimes kind of difficult.
So I saw Cliff, you move forward. I'm not sure Dr. Stain had ever shared that microphone with him. You might want to just go to the right.
He's leaning a lot to the right.
He's leaning. You can see him leaning away.
So VTE is a very difficult topic because, as we all know, that as an outcome, because the more you measure, the more you find. So it might be that better quality places who actually are more attentive to patient care have a higher VTE rate. What we're working on now with a lot of VTE experts is making a composite measure of an outcome, but also a process, because probably the skip measure of identifying the people, identifying their risk for the treatment that we should be giving them for prophylaxis, and then ensuring that they receive that is probably also a very important part. And so as we develop this, it's probably going to become a metric that has both a process and an outcome. So this excuse me, like a lot of things, this story's not done yet. It's going to be an evolution of how we do this, but that's probably where it's going to get to.
Dr. Stain.
One of the things I would say about NYSCP is they listen. There's conference calls we participate in, and I complained for a long time about how they didn't adequately adjust for ruptured aneurysms. And they have put in some measurements for adjusting for emergency. So I think the things we've learned is that you can give them feedback about things you're not happy with, and if calf thrombosis is one of the things that you think is not being adequately, Cliff's shop are able to listen and then come up with ways to fix them.
I think going along with what Dr. Pachter said, though, here at Cornell, every case of DVT gets analyzed to see if those patients had prophylaxis and what exactly was going on. And if we require feedback, the individual practitioner is given feedback on that. Any other comments about that question? Is there another question from the audience? Oh, there's one.
Paresh Shah from Lenox Hill and now North Shore, LIJ. Alphonse, I'm actually very curious about how you interface eComp with NYSCP, because I've got a very similar database, homegrown, where we look at every single encounter in the Department of Surgery, consult versus admission, same-day ambulatory surgery, and same model. The residents input the data, and as you pointed out, it's GI-GO, right? So we actually review every case, and the residents are charged with identifying complications, but then in our quality committee, we go through every case, even the ones that weren't, and pick out. And we usually find 2 or 3 cases every week that they didn't identify as something that needs to be discussed, but we do. But how do you take the information from eComp and interface that with what you're getting from NYSCP? Okay. Can you elaborate a little bit more on what you do there?
I can, but because we have a good panel and there's other in-house besides eComp, and I will answer the question, maybe Dr. Pachter wants to talk about in-house. How do you relate your dashboard to NYSCP?
That's really hard to say. I think the dashboard just allows us internally to see what's going on. It does not compare us to other hospitals. So I think that there's 2 different sets. So first thing, we're trying to get control of what we're doing in our own institution. Once we get that under control, then we look at how we're doing compared to everybody else. But we've got to get our own house in order first. That's for sure. But the key thing to that is verification of data. You have to be absolutely certain that the data you're having is either not missed or it's verified for it to be honest.
So what we do is we do quarterly reports, and this is resident driven, and the chiefs will present. So 4 times a year we get presentations. And during all those presentations, we actually, and I kept the slide shorter to fit into my time allotment, but we actually compare the data that we get from eComp versus the data which we get from NYSCP for our institution. And if there's no correlation, and again, the problem with eComp is if you report complications, you have to get out of that sort of mindset where you need to verify with the attending if you can report a complication. If I find a complication or a series like that, I have great authority and responsibility with my chair. The resident is addressed that the complications are not being reported. The other point being that if complications are presented in eComp, it's a negative reinforcement. In other words, if you report a complication, you may get chosen to present your cases. We used to present 4 now we present 3, which is sort of a time where 3 complications are presented a week. But you're guaranteed to get up on the podium if you have 20 cases and do not report a complication. So we've made it so you're going to have to report about an interesting case. So we try and use carrots and sticks. And when we look at the quarterly data, they wasn't always a good analysis, and it can vary from year to year and even quarter to quarter that there's no that there is lesser of a correlation, but the general figures are the same. The point is what to do with that, and we're grappling with that. We have a couple of residents who are very interested in quality, and actually it's a good part of the learning process now, as I mentioned in my talk, that part of the resident training algorithm that is required for the American Board of Surgery is some sort of system or improvement process, and this can be used, for example, at the New York Surgical Society this week. One of our residents presented on UTIs and what they'd instituted, and that became, an oral presentation, so this can be used. So you can sort of use, again, it needs to be carrots and sticks and move forward. It's a culture change.
Sorry, I meant specifically, what do you do, how do you integrate NYP data with your econ data? Do you try to reconcile them?
Yeah. So we use bar graphs saying this is how many infections we have reported in econ, this is how many infections we reported, this is how many UTIs, et cetera, et cetera. There was a question down here, yeah? Oh. Go ahead.
Bob Kurtz, I'm at New York City Health and Hospitals Corporation Central Office, the mothership, but this refers to when I was Director of Trauma and Surgical Critical Care at Kings County and downstate for the last 12 years. I'm asking this of Dr. Peters particularly, but I'd be delighted if other people had thoughts also, and it's about perpetuating what should be good cultural change and good practices. You thought there were people in the audience that probably had difficulties with that, and I'm one of them. I managed to lead the lowering of our CLABSI rate in the surgical ICU within about a year to what were then NNIS accepted standards. It took me 7 years to get it down to 0. And except for one case, we then had a 0 rate for the next 3 1/4 years. This was presented to NAPH. We got a prize for it. Last year, after the first quarter, which was 3 1/4 years of 0, we boomed up and had more infections than in the previous 6 years. I had gone by then down to central office. All the same people were in place. The same inculcated practices, I was told, were still being practiced. Hopefully the same zeal was there. And I chased this around. It's very elusive. I'm sure there must have been microscopic practice changes that people were probably not even aware of, because I know we had tracked, before we got to 0, we tracked down some stupid little things that were going on that probably did keep us from getting to 0 and eliminated them. What the later problems were, I don't know. But anyone who has an idea on this, I'd love to hear it. The rates dropped again a little after that, but it's very disturbing to have a graph like the one you presented, where you get a steady decrease in mortality and then boom, then it goes back up again.
Clearly it went downhill after you left.
Look, if I take credit for the good part, I have to take credit for the bad part too. So I'm glad to hear that from Dr. Packer, but I'm not relieved.
Well, I think this is one of our challenges. Perhaps we can hear from our state health representative whether that's happened in cardiac surgery in the New York State. I don't think it has, but I think we're all going to be faced with that because it is an element of human behavior, and I've looked into it also, and as far as I can find, there's not a lot of science around the causes of the recrudescence of an improvement process. Perhaps there is in industry or in other parts of the world, but it clearly is happening. It, I think, is complacency as much as anything else. Maybe not. Maybe it's processes bouncing back, but I think we need to understand it and try to fix it.
Maybe I have a small comment. When we see improvement in things that are difficult, like SSI, things like that, not UTI, taking out the Foley and making sure the right person puts it in, that'll fix a lot of UTI things. But SSI is very important. We just did a 2-year project with the Joint Commission, and they had all of their 6 Sigma black belts running around these 8 hospitals trying to figure out how to decrease SSI. And what they found was, it's really interesting that all these hospitals had something different that was probably causing it. So it's not you learn one and you teach it to all the other 7. It was going to be something different. Is a lot of the things that they couldn't figure out what it was that it was, but people got better. And whether you call it Hawthorne, whether you call it culture or whatnot, but it plays into what Pierre was saying about CUSP, that in CUSP, and it's not the only thing that does this, but when you get that culture, or whatever the word you want to call it, is that people tend to do things better, whatever they do. And it's not the 7 skip things of whatever those things are, antibiotics and the warmer and the clippers or whatnot, but there's a lot of there's probably 50 or 100 other things that we all should be doing, yet we're not measuring those, but people then tend to do those things better. And that's really a key of when we follow a hospital, when we watch a hospital, it's those things. It's kind of like the checklist. You know, everyone does 100% probably on the checklist, but you can go into an OR and watch a checklist when it's done meaningfully and when it's not done meaningfully. And I know that when I go into other ORs in our hospital, that they're wasting their time doing this checklist. Yet, you know, we check it off, that checklist was performed. And so it's getting to that state of itness, culture or whatnot, that's going to probably, and then having the curve go up, there's probably something happening with that as well.
I would agree with that, and it reminds me, the first NYSQIP meeting I attended, the college had done an analysis to see what's the secret about SSIs, and I seem to recall you guys, Skip Campbell visited some high and low outliers to find out what is it in processes, and nothing came out of it. The only thing they knew is when they polled each other, they knew if they were in a high or low outlier without knowing where they were. And they showed us a picture of an OR hallway, I believe it was, of a low outlier, and it was neat and perfect, and of a high outlier, and it was a mess. So it said that, I believe, you need an institutional commitment. I mean, the fact that Dr. Packer's dean looks at that makes a big difference. And you need a leadership commitment, and you have to keep doing it, and have the infrastructure to keep it alive. Because if you notice a problem and you form a little committee to address it, and they will figure it out, and everybody's going to do this thing, and the result's going to get better, and then they're going to go on to the next thing, you can be sure that people are going to take their eyes off the ball and do something good with the new project, and the old project is going to fizzle away. So the question is, how do you, that it factor? And I think that's a critical piece. Whatever you can figure out to get people to drink that Kool-Aid. And I think the most important slide today for me was Dr. Hoyt's slide, I think it was, that showed what the culture was and what it is now. And, you know, when we hear about all the talk here, everybody's going to go like, so let's go, let's all do that. Well, the part of doing all that is changing people's perception of what surgery is, from being what it used to be, where I can do what I need to. I'm a surgeon. My judgment is good enough, to no. You know, your judgment should be the last thing. We're going to put processes in place that will make sure we comply with all that.
So Jeff and I were talking last night about incentives for physicians, and we're talking about, but haven't done yet, is putting part of the physician's salary at risk for quality outcomes. And you know, the discussion is how much of that should it be? Does a couple thousand get his attention? Does 10%? You know, so I think where we're going to end up, where just like hospitals are at risk for outcomes, physicians are going to end up in our institution being at risk for outcomes. At Mayo Clinic, Claude Deschamps was telling me their chair's compensation is at risk for outcomes of the department. So I think that's where we're probably going to head up.
So Claude was my chief resident back in Montreal. I can just see his reaction to that. Just one point before we move on to the next question. There's several quality initiatives, and the Institute for Health Care Improvement actually gives a course, and that's a long sort of a week commitment or a 4 or 5 day commitment. And I took home 2 messages about that type of a problem that you were facing with the catheter-related infection. One is to analyze those catheter infections, each one on an individual basis, with a group of appropriate stakeholders, as Pierre has mentioned. So you can't only have the doctors looking at it, you have to have the SICU nurses and probably the people cleaning the rooms in the SICU and get everybody sitting down at the same table. And so that's not what I learned. What I learned was 2 problems, the 2 major issues that will come up at that type of meeting will be responsible for about 80% of your problems. So all you really need to do is identify the first 2 problems, institute change on them, and then do that cycle one more time, and you've solved about 95% of your problems. And they use many examples, and I think it's very true about a lot of things in life besides surgical infections or surgical problems. The second thing that I learned from it is you don't need a big group of people. You don't need the whole institution to buy in right in the beginning. So if the people in the intensive care unit, as you're talking about, where those catheter-related infections believe that it's a problem and they're given the data, as several presenters said, here's the information, this is what you look like. You know, you think you're the best, but we're not anymore. So what are the problems? And then you institute small steps for change. You don't institute institution-wide. Not every SICU has to, or not every institution intensive care. And once you've proven and you work out the lumps and bumps and the problems in the road, I'm mixing my metaphors, but once you've eliminated those problems, then you can institute it on an institution-wide basis and then carry it forward with different collaboratives. There was another question?
Yeah.
Go ahead.
My name is Peter Rizzo. I'm an orthopedic surgeon. I practice up in Westchester. To further answer the question, where am I from? I'm the caboose of, I think, 90 years emanating from Cornell, having preceded by my grandfather and father and uncle. I had two comments and then a question. The comments were, I think, first of all, with respect to the residents and the students, I think you should take advantage of them, put them on the QI committee at the table, if there's room at the table, and I think that'll help disseminate the information from below and get it to above. And I think you got a very smart group of students and residents, and it behoove you. Number two is with respect to all the comments made on urinary tract infections. We wrestle with the same problem at our hospital. And when you drill down the data, you realize that over the years, doctors and nurses rubber stamp just urinary cultures as UTI, so to speak, and it's gotten us into trouble because, that's really asymptomatic bacteriuria, and we're dinging ourselves when we shouldn't be dinging ourselves. And the question I had really to the administrators is that how will you address these quality initiatives with the vendors? Specifically, we have our companies coming in with our products and our new products, and certainly teaching institutions have a bigger responsibility than community hospitals. But they have to buy in from the day they come in. And I want to know how you're going to address it at your institution so that, when we have these recalls, when we have these problems, we get dinged on so many levels, and they have to have some more something more into the game for us to be more confident that we're not going to take the total hit on this. And I'd like your comments on that.
So at your institution for device recall?
Any devices.
Any devices. Interesting. Who wants to step up?
Well, we recently went through an issue with, I think, mainly New York hospitals about our cardioplegia solution came from the same company in Massachusetts that had the epidural stuff. And we had to go back and I think the state actually helped us through this. We're going to have to contact 400 patients used over the last 6 months that had heart operations, none of whom were symptomatic that we could tell. But I think as an institution, we work with our other institution in the region who also use the same cardioplegia solution. And we eventually came up with a letter we sent to patient the state helped us draft. But the vendor had nothing to do with it. It was our responsibility because the state, the CDC, said we had to do something. So I think we can try and hold vendors responsible, but I think ultimately if we're taking care of the patients, we have to make sure we do what we think is best.
Go ahead.
We had a similar thing. I think many of you will recall that the implants for hernia, one of the company, I think it was Bard, they had a rigid ring. And I think 2 or 3 of them had broken, the ring broke and perforated the bowel.
The Google patch.
The Google patch, that's right. So they were recalled, and every patient that we had put one of those in by state, we had to send them a letter telling them that this has been recalled. There's only 2 or 3 patients that it happened to, but you should be aware of that. The vendor, they're going to get sued for whatever that is, but there's no relationship between shared responsibility, for something that has happened like that, not that I know of. But while on the issue of, these vendors, I'd like to also point out this comparative effectiveness. I walked into the OR the other day, and one of my attendings casually just asked, well, give me 20 loads of the endo-GIA. 20 loads. I mean, I don't know what the cost of this is.
And many of them, you can just put a stitch in there and tie it, and as opposed to putting $100 or $150. So, the government, after a while, is not going to be paying for this thing. If you can get the same effect, cost, by putting in a suture instead of, I don't mind using 1 or 2, but when you ask for 20, you have to be cognizant of that. So our institution has started this program of gain sharing, and they're looking at comparison both to UH Consortium and NYSQIP, how much it should cost per operation. And if you go under that and the hospital makes some money, they will give you a percentage of that, and that's an incentive.
It's a very interesting point, and I think the question is very appropriate, because if the institution continues to buy a product which is based on price, usually, and most things that are cheap, and then the surgeon and the hospital, the surgeon takes responsibility for putting in a product. But there are certain innovations that can be brought in a more positive fashion. For example, we have recently here, using a lot of laparoscopic approaches, we use an energy source called the harmonic. That's probably a brand name. But we looked at what we call reposables, which are objects that were formerly, or instruments that were formerly discarded, and now they get cleaned and get reused. And I figured the surgeons would react to that in a very negative fashion, because they would say we're getting an inferior product. So instead of obligating them to take it in, I convinced OR management to actually run a sort of prospective trial where we tried 200 of those against 200 of the new ones and saw if there were adverse events and going out throughout, and there weren't. So when we moved over and made a substantial, and this is what Dr. Corwin was talking about when we talk about Hercules projects, which is sort of cost-effective methods to save money in the institution, we got a product that we thought would be inferior, but it actually wasn't, and it's worked out very well, and it's saved hundreds of thousands of dollars over the course, and it was adopted without any fanfare or so when things are applied sort of in a fashion that you have input into it, it's different than when things are forced onto you. So we have 3 more questions. Go ahead.
My name is Oliver Fine. I'm a general internist, not a surgeon, and associate dean here at Cornell. So my questions may actually come out of a little bit of an ignorance. I think this is wonderful to hear this panel talking about your program of NYSQIP, but I'm kind of curious what it costs an institution to participate in the program, and secondly, how your risk adjustment is being done, and to what degree the risk adjustment takes into account socioeconomic status, race, and other factors besides comorbidities.
So I'm going to ask Pierre to say how much it costs, and I'm going to ask Cliff to talk about the risk real quick.
Cliff said we could get it for free.
Dr. Hoyt, if you're in North Dakota.
Right. There's a participation fee that is currently, what is it, 20?
It's between 10 and 20.
$10,000 and $20,000 for the, having the web-based program. The real cost is based on your volume and how many FTEs you need to associate with it to abstract these cases. So it could be 1 person, it can be 2. You have 1.5, I think.
But an FTE is a professional FTE, so it's going to cost you 60, 70 plus fringes.
Yes, right? so that's really the real cost. And if you want someone that's competent there that can do the job right, then you need to find the right person. Because that person is critical for your data and for the feedback you're getting.
And as we move forward with the program and try to get more things automated with the EHR or an XML uploader, and there's less time spent on collecting the data, more time can be spent on the QI part. And probably the SCR, and I don't want to disparage the surgeons and their role, but the SCR probably knows the data probably the best and kind of sees everything and putting in, getting it out, and runs the reports or whatnot. And has been and will probably continue to be a crucial part of the QI from NYSQIP.
Can you talk about risk adjustment?
As far as the risk adjustment, we made a decision very early on to be very clinical, and we do get we can do socioeconomic status and race and all those types of things, but especially with the decision of the way CMS goes and the way NQF goes, we've decided to be consistent with that and really just use clinical points for the risk adjustment.
All right. Another question?
Yeah, Peter Schmalman from Montefiore Medical Center. I just want to follow up with that because when you mentioned this, Cliff, that we're looking at measures sometimes the same thing in two different ways. So we have a group of coders that I oversee for quality and a group of coders that we oversee for NSQIP. Give us an idea of the potential or the timeline that you think maybe NSQIP would come in to weave those things together, because I firmly believe that the NSQIP data is more accurate, timely, and actionable for surgeons, where some of the other measures that we send to the state, CMS, and even local PI projects may not be as good. And if we could have that ability to take some of those other coders and put them in the front of quality rather than quality reporting, but really quality and safety improvement, that would be a real plus, because as the last speaker mentioned, the money's sort of not there for everything, so we have to be very careful about that.
Yeah, so as we work with the government, it just things sometimes move really fast, sometimes move really slowly. And as we've uncovered these huge differences in terms of the data source, they absolutely want to use the best data. I really believe that. Dr. Hoyt was with me at CMS, and they really want to do that. It's just operationalizing it. And how do they do that when all of these systems are in place for different data sources? But they absolutely want to do that and moving towards that. We have, for example, with SSI, I'm sure your hospitals participate in NHSN, and even that is a clinical data source, but they have very different ways of looking at it. For example, if an SSI occurs and the patient is discharged on Monday and the SSI occurs on Tuesday at home, that SSI is not counted unless the patient is readmitted to the same hospital and it's counted there. Then they count. So even things like that within a clinical data source, it's different, and we are working with the CDC right now to harmonize those things. I can't give a timeline, but we've identified a lot of these things and are moving towards getting it hopefully done in a better way than it is now.
Next question.
I have one more question. It's sort of been answered, but Dr. Pachter talked about the liver transplant surgeons. Anyone gaming the system, the patients are transfer off, patients not coming back to the same hospital. I mean, zeros. My hospital claims they have no ventilator-associated pneumonia. Is kind of ridiculous. But, I mean, is there a zero? B, are we looking at randomness in all these graphs? They go up, they go down. How do you know that it's not just random?
So statistics.
Wow. Oh, go ahead. No, go ahead.
Somebody. Oh, no. Happy not to talk.
I'll just say that we're all under the same thing. I think at least when we start. But I'm watching this data now and all the quality data. It is not random. It is not random. I just showed you a half a dozen slides of a clear trend line over 5 years. I think any mathematician would tell you that's not a random event.
Cliff?
Exactly. Thank you.
So, are there any other questions or comments? Yep, go ahead.
This will have to be our last one.
This will be our last one.
I'm Van Norman from Amsterdam, and in the Netherlands we embarked on doing a registry a couple of years ago in colorectal cancer, and we have now experience for 4 years with it. These databases we have to fill it in obligatory. We have an inspection of healthcare, and every year they ask us at the end of the year how many of our colorectal cancer cases are in this database, and you should have 100%. We don't. Through the whole country, we don't have 100%. It's 97%, and the 3% which is lacking, we realize that there is a part of the mortality we have in colorectal cancer surgery in the Netherlands. So surgeons are tended not to fill in the bad cases in the database. So it's very important that we have monitoring of the data in the hospitals. And the other thing is that what we notice is that it might change the practice of the surgeons. And that they have more defensive surgery. Of course, we also have a case mix correction. But for instance, if a patient comes in with obstructed right colon and it has metastasized disease, you can decide, well, we just put a stoma, or we don't operate this patient. So it won't show bad in your database if this patient dies, because it really determines your mortality rate. So what about the US? Your country, do you have any idea how the surgical practice is changing because of these quality systems?
Dr. Gaston, you want to take that? So basically, I guess the question is, do you cherry pick either your patients or your operations? Because if you have to report them to a database and you get evaluated publicly on that database, you don't want to have bad outcomes.
So as long as I don't put my mouth on this, right, I'm okay? I can still talk into it. And
don't shake hands with them either.
So it's a really great question, and there's a lot of, I mean, it's hard to separate how much is urban legend from fact. And I would say that the system around which there's been the most discussion and study around this has been cardiac surgery in New York. And there have been articles that have gone back and forth about folks avoiding very difficult cases so that they don't show up on report cards and so on. And I would say, depending on which articles you believe and who you believe and which ones you've read lately, you may come to different conclusions. But one of the things that is striking is that we've not seen, I mean, some of the things have been about out-migration or reluctance to take complicated cases that flies in the face of the data, which shows actually an increased complication rate of folks that are being operated on. So it's hard to know. I think that that's a legitimate concern that people have. One of the things we didn't talk about very much in terms of quality and safety is people who potentially should not have certain procedures. It's another quality issue. It relates certainly to cost, but also relates to safety, and that's a more complicated one. So in some instances, is that avoidance a good thing, a bad thing? Again, a matter of great debate and discussion. But I would say that there's a constant concern about that. Maybe the folks to my right can comment on whether you've seen it as a reality, given the programs that you've been running.
We're going to have to close it down because it's time. But maybe that's the answer to your dilemma, Dr. Peters, is that you've become so good that they're sending you all the difficult cases in there. On that note, I'd like to thank all the panelists here for their presentation. I'm going to pass the podium off to Dr. Michelasi for some concluding remarks. And Fabrizio, go ahead.
Alphonse, thank you very much, and I'd like to thank all of you for your active participation to this quality forum. Certainly, all the panelists and all the speakers really deserve a round of applause. They did a fantastic job. I thought that this was an outstanding morning on quality, and we all need to thank the American College of Surgeons for the leadership that it has provided over the past 10 years with this program in quality. Thank you very much for your participation, and delighted that you could come.
Thank you so much.